we are all set to go.
Good afternoon, everyone. I'd like to call this meeting to order. Great to have you all. We're looking forward to your testimony on a variety of bills, and we're looking forward to lots of love in the room since it's Valentine's Day. So thank you all for those who brought us treats. I'll kick it over to my co-chair, Representative Wood.
Thank you, Mr. Chairman. Happy to be here. Looking forward to hearing from everyone. We really appreciate you taking time out of your day to share your stories with us.
Thank you, Representative Wood. Representative Berry, anything else?
I'm happy to be here and happy Valentine's Day to everyone. Thank you.
Thank you, Representative Berry. Any comments from our rankings?
Thank you, Mr. Chair. We have a number of bills here, and I want to thank all the advocates who are here today on St. Valentine's Day, wishing everybody a St. Valentine's Day. I want to thank you for your advocacy on your specific area of interest, and we're here to hear you, and thank you for being here. Happy Valentine's Day. Thank you, Mr. Chair.
Thank you, Senator. Representative?
I'd also like to thank everybody. And I know some of these are personal stories. However, our job is to make these, pass laws, but make some of the bills or some of the ideas better. So some of our questioning, just remember, is the purpose behind our questioning is to make a bill or a concept the best it can be. And that's really the only reason behind questioning. So, if we ask a couple questions, please, if you don't have the information, if you could get it to us in the future, that would be great. But again, thank you, everybody, for coming to testify on these bills.
Thank you, Representative. All right, we'll get right to it and get going. I see Senator Kissel's here. Senator Kissel?
Good afternoon. I'm State Senator John Kissel, representing 8 towns, all or part in North Central Connecticut, representing the 7th Senatorial District. Chairman Cabrera, Chairman Wood, Vice Chairs Anwar and Berry, and Ranking Members Wong and Pavlak D'Amato, and esteemed members of the Insurance and Real Estate Committee. I'm here with 3 guests, 2 of which are my constituents, urging you to support their proposal regarding Senate Bill 976, an act concerning health coverage mandates for certain health conditions. The proposal that they're concerned with is called colloquially PANDAS, just like the bear, but it's an extraordinarily rare and serious disease that afflicts children. PANDAS is a shorthand for pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections and pediatric acute onset neuropsychiatric syndrome. To my immediate right is my constituent, Carrie Woodbury, and to her right is her daughter, who's a junior in high school in Suffield, Jordan Woodbury, and they're here to talk about her son, Carrie's son, and Jordan's brother, Joshua, who became afflicted with this disease when he was in 3rd grade. And to their right is Gabriella True of West Hartford, and she's the president of Aspire. And I'm not going to try to mangle what that stands for, but it's an advocacy group regarding the many hundreds of people suffering quite often in silence through a loved one that has PANDAS. And so at this time, they have the real story, and I just like to turn my time over to them and turn it over to Carrie Woodbury, just talk about what happened to Joshua and what they're fighting for regarding what's not available to people and what really should be available to people when a loved one, especially a child, comes down with this. So if I may.
Yeah, proceed.
Honorable members of the Senate and Insurance and Real Estate Committee. My name is Carrie Woodbury. I'm the mother of a child with PANS, and I support Senate Bill 976. Had there been proper insurance coverage and education to diagnose and treat our son, he may have had a chance to live a normal life. Our son does not know what it feels like to be healthy. He suffers from OCD, head and verbal tics, headaches, urinary frequency, insomnia, behavioral issues and outbursts, regression in decision-making skills, and numerous mistakes from school. Despite being treated with multiple courses of antibiotics, there has been no lasting benefit. We sought out specialists to try and get IVIG treatment, which our son was never able to receive. Thousands of out-of-pocket dollars have been spent just seeking proper treatment, which in our experience has been unobtainable. Our son has suffered physical, social, and emotional trauma, which could have been avoided. Not only has PANS affected our son's health, it completely hindered his life. We woke up on one day and our sweet, loving little boy had disappeared. His demeanor had been completely altered. When someone has a broken arm or leg, we can see the fracture and mend it. When someone has PANDAS or PANS, we cannot see the antibodies, which are supposed to fight off infection, attack their brain, and cause the brain to swell, impacting their ability to control certain behaviors. Our son was eventually placed on a 504 plan with accommodations. Even though he was on a 504 plan, the administrators and teachers labeled our son a bad kid. He was denied trips to the nurse for Tylenol and use of the bathroom without an escort. He was treated harshly, and his consequences for his actions were often more severe than his classmates. Despite written and verbal communications from our medical specialist and legal counsel on how to interact with our son, the school continued to discount his condition and symptoms related to PANS. Unfortunately for our son, his entire senior year was taken away from him. He will never have his senior year and experience such things as prom and graduation or being a senior basketball player for which he lived for and was so talented at. You might think this proposed bill is not important because PANDAS and PANS affect such a small portion of our community. The truth is we don't know exactly how many people it affects because it goes undiagnosed or misdiagnosed all too often. I am imploring you to consider Senate Bill 976 and include language for coverage of the diagnosis and treatment, including IVIG treatment for PANDAS and PANS. You have the opportunity and power to make a difference. No one suffering from this condition should ever be denied proper medical treatment or have to endure such mistreatment from society. With your help, we'll continue and pray for healing. Thank you for your time and consideration.
And with your indulgence, we have the two other speakers. Jordan, who just wants to speak briefly about what it was like having a sibling with this. And again, Ms. True for her association. Jordan.
Honorable members of the Senate and Insurance and Real Estate Committee, my name is Jordan Woodbury, and I am the sister of a brother with PANS, and I support Senate Bill 976. Growing up, it was always my brother was sick or he wasn't. Every doctor's visit, he was constantly on medication. My brother would always have these episodes, and I could see he was struggling. I remember when we still went to the same high school, it was always someone liked him and thought he was a good kid, or they would just assume he was trouble. His actions may have caused this, but no one saw the disorder that was underlying cause. No one understood what my brother was going through or who he was as a person. Personally, it broke my heart to hear the judgment people brought towards him. People who suffer from this disorder are not recognized and no one understands. No one knew the boy that I knew as a brother. No matter the episode, I could still see my brother in him. Had my brother had the access to the proper medical treatment, perhaps his life would have been different. Had there been more education about his condition of PANS, perhaps people wouldn't have brought such harsh judgment against him. By providing coverage for individuals with PANDAS and PANS, you will be helping people like my brother have the opportunity to live a better life physically, socially, and emotionally. I'm asking you to consider Senate Bill 976 and include language for coverage of the diagnosis and treatment, including IVIG treatment for PANDAS and PANS. Thank you for your time and consideration of Senate Bill 976.
And Ms. True.
My name is Gabriella True. I'm a resident of Connecticut, a mom of 2 children with PANS, PANDAS, and myself has PANS. I am president of a national nonprofit dedicated to advocating and educating about PANS and PANDAS. Please support SB 976 with the addition of the proposed PANS, PANDAS language. So PANS and PANDAS are devastating but treatable neuroimmune disorders. After a strep or similar infection, a misguided immune response triggers an inflammatory process in the brain, resulting in neurological and behavioral changes. including but not limited to OCD, separation anxiety, depression, aggression, severe learning difficulties, tics, and other debilitating symptoms. The lack of insurance causes unfathomable suffering by creating an often insurmountable barrier to care. Like most disorders, early diagnosis and treatment lead to better outcomes. Unfortunately, children are often misdiagnosed as only having a psychiatric disorder instead of a neuroimmune disorder. Since diagnosis always determines treatment, they are given the incorrect treatment and symptoms get worse. However, children who are appropriately treated within the first year of symptoms often recover quite quickly with very simple medication, but those who do not often require more invasive, costly, and lengthier interventions to recover. Without correct treatment, symptoms simply do not resolve and can become chronic. Children essentially lose their childhood and can be consigned to suffer a long-term disability. A small amount of children fail to improve with less expensive medications like antibiotics, NSAIDs, or steroids and need immunomodulatory therapy, included but not limited to IVIG, intravenous immunoglobulin, a pooled blood product.
Excuse me, that does eclipse the 3 minutes. Please summarize.
But without insurance, while acknowledging the cost of immunotherapies is substantial, it is small in comparison with the cost of emergency interventions, inpatient psychiatric treatment, hospitalizations for starvation, aggressive behavior, suicide, and self-injury. Insurance does not deny other high-cost medications for other disorders like Lipitor, high cholesterol, Humira for rheumatoid arthritis. Failure to treat does not erase the problems. It creates new and even worse problems that shift even greater financial burden to families, the state, and its school system. And no parent should have to make the choices they have to make. It is fiscally more responsible to treat PANS than create a situation of lifetime care. There are 10 states that have passed this, 3 in New England, including Massachusetts, New Hampshire, and Rhode Island. Connecticut needs to do better. I did not get to share my story. My son's is up on the site.
Thank you. Thank you all. Senator, thank you. And thank you all for your heartfelt testimony. I really appreciate you taking the time to come speak to us today. Thank you very much. Senator Wong.
Thank you, Mr. Chair. First, thank you, Senator Kissel, for raising this important consideration on behalf of your constituents. You've done this many years. I wanted to acknowledge your contributions and your advocacy on behalf of your constituents. If you could, Ms. LaTrue, finish up the story of your son, if you could.
Well, I have 2 children with PANDAS. One has severe autism. It's very complicated, but my other son, who was more neurotypical, he should have been diagnosed in kindergarten. He had his next big flare at 8th grade, which ended up at Institute of Living after writing a suicide note that he handed into his teacher. Then he started treatment. Like her child, it wasn't quite enough. So at 10th grade, he had another big devastating flare. He was not able to get IVIG. We tried to go to Boston. We tried to go to New York. We couldn't make it to New York, and it was out of pocket and simply prohibitive cost-wise. He spent 2 years basically in bed. Then when we got him out of bed, he was outplaced or in place within West Hartford at one of their specialty schools. He didn't get he had been a grade A honor roll student at Hall High School, captain of the defense team of lacrosse, almost Eagle Scout, and then everything fell apart. He was crippled completely mentally and physically, and just no sign of getting better. We kept trying antibiotic after antibiotic. One worked. We made a risky choice because of the infection that was causing this to try steroids. We were on suicide watch for many, many weeks and months where my husband and I rotated. Even if we brought him to the ER, they would just send us home and were absolutely no help. Not that it would have been enough because a psych ward doesn't treat neuroimmune disorders. And he finally did graduate, but we had to put everything to pass fail. The 504 is more than a 504. It should have been an IEP. The school admitted it. One time he had an outburst at school, and it was a big one. And they knew they hadn't done well by him at all. And so that's why he got the outplacement, because he couldn't handle being in a regular setting. But now he's doing okay, but he lives in constant fear of a relapse and not being able to have the access to the treatment. He goes, he's at Lincoln Tech to be an electrician. He's getting straight A's. But every time he gets sick, the entire house is like in a state of panic, just watching, waiting for a neuroinflammatory post-infectious response to happen. And he doesn't get sick with every infection. Thank God. Some kids do. His brother only gets sick with strep. Xander happens to get sick with a few other things. So he's really concerned that he will not be able to get care, and then he won't be a functioning adult at all.
Thank you. And thank you for advocating for your son. Ms. Woodbury, if you could quickly, one of the challenge of this PANDS, it's an acronym, autoimmune neuropsychiatric. It is a very difficult disease to diagnose because it could be caused by strep throat, but then the evolution and manifestation is psychiatric and mental health aspects of behavior. Can you share quickly what your experience is and how you learn about this, how we can educate more people? And it qualifies as a rare illness. Would that be correct?
That's
Maybe
correct.
share your experience and educate us about this, because that's one of the important parts that Senator Kissel has really reiterated is most people don't understand this. It could be symptomatic of so many different things. And for us as a legislative body, we focus so much in the last number of years on mental health. It is a manifestation of that, but subsets of it. Could you share with us a little bit?
Correct. We were sort of lucky in the sense that Joshua's pediatrician had been doing some research and knew about PANDS back 11 years ago. And so back then the treatment was mainly antibiotics. And we treated him with the antibiotics and he would get better and then get sick again because he was susceptible to anything. PANDS, if you get a cold, if you have a sinus infection, anything like that, you'll have a flare up. People don't recognize it. He was labeled a bad kid. When he would go on his treatment of antibiotics and didn't get better, he was a perfectly normal child with normal behaviors, nothing psychiatric, anything like that. But with the flare-ups, they turn into a completely different person. There needs to be education, especially in the school systems, so that these children are not mistreated. And it's not just children, it's older adolescents as well that it inflicts. And it goes, I think, masked that it could be PANDS or PANDAS and be treatable, but it's looked at as maybe just a psychiatric disorder.
Thank you very much for your advocacy. Thank
You're
you,
welcome.
Mr. Chair. And if I may, just one last second to have Senator Kissel maybe close out. Thank you for your advocacy on behalf of your constituents.
Well, sure. I don't know if there's any other questions by members of the committee.
Yeah, just 1 second. Senator Marks has a question. Senator Marks?
Thank you. Thank you, Chair. So I was a pediatric nurse. I've been a nurse for 40 years for the first, I forgot now, like 15, 20 years. And I hung IVIG a long time ago. So it's not like it's a new medication or treatment. So were you not able to get your family the IVIG because it was not, the insurance companies refused to pay for it?
Yes. So,
No, let Mike.
okay, sorry.
We were not able to get it. We went to specialists and we were told we had to go to other specialists to have certain other testing done to see if he was eligible for the IVIG. And in any way, even if he was eligible, it was so expensive that it was unobtainable for us anyways. But we never got to the point where it was even an option for him because he had to see so many different doctors. I'm not sure exactly why he had to go to so many doctors to determine that.
Yeah, it's frustrating. That's our healthcare system. And then how is it diagnosed? Is it just by symptoms or can you actually do a blood test or a CAT scan? How is it actually diagnosed?
It's diagnosed by symptoms.
Just by symptoms.
Yeah.
And have they tried any biologic agents since it's an autoimmune disease? I know now there's a lot of other new most autoimmune diseases now, as you can see with all the commercials on television, are being managed by biologics, but that hasn't been tried with PANDS.
No, not
No.
with Joshua. No,
So he never got to have the IVIG.
no, that's correct.
I'm so sorry.
Thank you.
Yeah. I'm so sorry. Thank you.
Thank you, Senator. Any other questions from the committee before we ask Senator Kissel to sum up? Senator Kissel.
Thank you very much, Mr. Chair, and thank you to esteemed members of the Insurance and Real Estate Committee. So it's rare. It's I think, as Ms. True would testify, there's probably hundreds of people suffering from this in Connecticut if it were diagnosed, but certainly not more than thousands. And there's true financial hardship, but we made this effort as a legislature in the last 2 years regarding mental health, its relationship to the pandemic. Unfortunately, this is something that is fundamentally based in physiology. And when those white blood cells, then it ends up attacking your own body. And because they're not checked, they end up having a disproportionate impact on the neurosystem, causing these aberrant behaviors, these outbursts that are misdiagnosed. And so and I thank Senator Marks for her question, because this is treatment that is not new. We're not looking at cutting edge research, but just a mom or dad's ability to access this. And unfortunately, this is financially driven to a great extent too. You have the battle of trying to figure out what this actually is from a physician. And if you're lucky, you'll have one that's familiar with this. And once you get the diagnosis, then you tap into your insurance and they say, well, we don't cover that. We may not even be aware of that because it is a complex disease. So these folks have suffered through it. I mean, Ms. True, I can't imagine having not one, but 2 children. And so I know she's got a lot that she wants to testify on, and maybe she'll testify later today. Jordan, seeing in school her brother being mistreated and looked at as a bad apple when he really has just got this physiological impact on his brain, causing him to act out. That's got to be heartbreaking. But again, to Ms. Woodbury, seeing her third grader, and she said she was coming back from a swim meet and looked in the back seat, and all of a sudden he had this tick, and she knew. She goes, "That's the day I lost my son." And so it's within your ability to make this a part of someone's health insurance plan. My guess would be that the financial impact would be de minimis. You know me, I'm not a huge champion of unfunded mandates. But that's in this instance, with the small amount of youngsters impacted, and it's hugely negative impact, and the fact that we have the medicine and treatment to turn this around, the lives that'll be saved and lost, it's within our grasp. And so many things aren't, but this is. So I thank you for your time and attention.
Thank you, Senator. Thank you all for your helpful testimony today. I really appreciate you taking the time. Thank you so much.
Thank you.
Senator, I'm sorry. Senator Anwar has his hand raised on Zoom.
Sorry, Senator. 1 second. Senator Anwar, please proceed.
Thank you
sir.
so much. Thank you so much, Mr. Chair. I just wanted to thank the individuals who came in and Senator Kissel for his effort in the testimony. I just wanted to add that from a perspective, it's just a comment, it's a short comment that I wanted to make, that the number of patients are very few, and the treatments with IVIG and even the immunomodulatory treatments may help. So the cost to the insurance industry is not going to be as much, but it's going to change the trajectory of the patients. So this is showing results with some of the opportunities. So I do think this is worthy for us to pursue. I just wanted to make that comment. Thank you so much.
Thank you, Senator. Anyone else on Zoom, Mr. Clerk, that I'm missing? No. Okay. Thank you very much. Appreciate
Thank you,
it.
Mr. Chair.
Thank you for your time. I think our comptroller is on Zoom. Comptroller Sean Scanlon. Are you there, sir?
I am. Good afternoon, everybody. Happy Valentine's Day to the committee. And I am sorry that I can't be there in person today, but thank you for allowing me to testify on SB 437. Now, when I was chair of this committee, I did not like when people came and testified and read their testimony that were elected officials. So I'm not going to do that today. And I will just instead summarize my testimony. Josh Wojcik, who is the the health policy director of our office, is here with me today to answer questions and look forward to having a discussion about this. But Chair Cabrera, Chair Wood, Senator Wong, and my old friend, Rep. Pavlak D'Amato, good to see you all. And thanks for, again, having me today. So I believe that this bill, while perhaps well-intentioned, is not necessary, and I'll tell you why. First and foremost, our office and therefore this plan and all plans, rather, both the state employee health plan and the partnership plan are already audited every year by the auditors of public accounts, which, as everybody on this committee knows, is an independent agency that already fulfills a lot of the functions that I believe SB 437 is trying to impose. These are people who have a lot of financial expertise and certainly know a thing or two about auditing and really do a comprehensive look at everything that my office does and every state agency does, but specifically these health plans. But secondarily to that, my office is known, certainly prior to me, since I've only been there for about 2 months, but has a history of transparency. My predecessor, Kevin Lembo, made that a huge priority. And as a result of a lot of the reforms that he put in place, we now have a much more transparent and open government than we did even 10, 15 years ago. And as a result of that, we each year put out a plan or a report rather on the partnership plan in January of every year. And that plan, which was one of the first things that I did as comptroller, didn't shy away from discussing some of the tough realities that the partnership plan faces. That report is very candid and very forthcoming about what I thought the challenges were, what my office thought the challenges were. And anybody who's interested in learning more about that can certainly read that report. But beyond that annual report, we release different facts and information on a monthly basis and a quarterly basis. So each month we go before the Healthcare Cost Containment Committee and share exact real-time numbers of what's going on with both these plans and subject ourselves to questions from that committee. But we also make sure that we are releasing other information to the public when it comes to utilization and enrollment reports, both the partnership plan and the state employee plan on Open Connecticut each spring and fall. And every single vendor payment that's made on behalf of the state health plan is updated to the Open Connecticut portal on a nightly basis. So look, certainly always believe that transparency is important. I certainly have made myself very available to even members of this committee who have raised questions and concerns, and we've sat down and talked about this. And we are more than happy to release any and all information that we're able to when it comes to the health of these plans. But I think it's important to know that in addition to the already audit that we do every year, we also are working with actuarial consultants that are nationally recognized on an annual basis to set these rates and do so in a way that is not just leading, I would say, in terms of getting the right answer and how we set these premiums, but also making sure that all the information is available to people if and when they want to see under the hood as to how we actually do that. And that commitment will always continue from me, but I do believe that this bill is unnecessary given what we already have in terms of public transparency and the audit that already happens every year. So with that, I'll stop there and take any questions that the committee has.
Thank you, Mr. Comptroller. Any questions, Representative Barry?
Thank you, Mr. Chair. Thank you, Mr. Comptroller. Good to see you.
Likewise.
So you mentioned in your testimony that the auditors of public accounts have existing authority to perform an audit. Has an audit, a specific audit, ever been done over the partnership plan?
Representative, when you say a specific audit, I think that the answer to that is, as I said in the testimony, they audit our agency and therefore they audit the health plans every year. To my knowledge, and Josh can correct me if I'm wrong, they've never done a specific audit about just the health plan, but they audit the health plan and everything else that we do and everything else every other state agency does on an annual basis.
Okay, thank you. So I have seen specific audits over the retirement plans and over OPEB, but I haven't seen anything over the partnership plan. And understanding that you are new, would you be open to an audit over the partnership plan?
Well, what I'm here today to say is I don't think it's necessary. We put out a report every January outlining the exact specific figures of what happened in the partnership plan the previous year. And I don't think anybody who read this year's report could ever accuse me of trying to sugarcoat what the situation is with regard to the partnership plan. But even if you don't take my word for it, we do release any and all of that information as to what's going on with the partnership plan every month at the Healthcare Cost Containment Committee. So if you're saying, hey, I don't want to wait till January to find out what's going on, that information is available every single month. You can see what the MLR is, you can see what the utilization is, you can find out up-to-date information as of that day in time in the month of what's going on. And then when you pair that with the report and the fact that we get audited every year by the APA, I just don't see what a third or independent audit would do beyond what's already happening from an independent audit and the information that we voluntarily agree to release, and any information that any legislator or member of the public has in addition to those formats that we're always happy to comply with.
As a former auditor, I see a lot of value in audits, and they're designed to spotlight the things that you're doing right and to identify the areas that need improvement to ensure future success. So are you aware, so when you say that the auditors they audit the comptroller's office as a whole?
That's correct, Representative.
And are you aware that there have been significant findings in prior audits for the comptroller's Department of Operations?
It's my understanding that each time the auditors make a audit of any agency, they always find some sort of problems. No agency is perfect. There's always things that they find, and certainly I can't speak to past audits, having not been the comptroller until last month, but certainly can say that going forward, I take the audits and the findings very seriously, and we'll certainly work to address anything that they discover in those audits going forward.
No, I understood, and that's why I bring that up, because they do identify areas for improvement that could help ensure the future sustainability of the plan. My last question is there an independent actuarial evaluation prepared for the partnership plan?
Josh, can you address that question?
I can. Yes, each year we have contracted actuaries for the state plan, and they analyze our claims data and underlying trends in the marketplace, and then provide the premium increase or change for the following year that is required for the plan, and relative to legislative requirements, that premium increases for both the partnership plan and the state employee plan.
Okay, is that available for the public to see? I was not able to find it anywhere on the website.
Yes, we can share the actuarial evaluation both for last year and the projection for this year that helped to set the governor's budget projection.
Okay, thank you. I appreciate that. I'm all set, Mr. Chair.
I'll make sure that Kevin Kurian, who's our legislative liaison, gets that to the chairs, and the chairs can disseminate that to the members of the committee after this meeting is over.
I appreciate that, Mr. Comptroller. Thank you.
Thank you. Representative Chu.
Thank you, Mr. Chair. Thank you, Comptroller, for coming to this today to talk about this, and thank you for meeting with me when you did to discuss the partnership plan. Having time to think about everything. I do have a few more questions, if that's okay.
Of course.
Thank you. One of the questions that I have, sir, is beyond the administrative fees that are paid by the insurance carrier regularly, what is the direct cost for the comptroller's office in administrating the partnership plan?
Josh, can you just talk about the staff?
Yeah, so we have staff that whose a portion of their time is spent on administering the partnership plan, and I apologize that I do not have the exact numbers in front of me, but it's several.
It's six. It's 6 employees.
Oh, 6 employees. Yes, it's about 6 employees. And it's in the hundreds of thousands of dollars that is covered by the partnership plan, and that incorporates both their salary and their fringe costs that are associated with their time working on the partnership plan, and that those fees are incorporated into the partnership premium and charged out to the partnership groups that participate in the plan.
So they're included in the premium. Are they included in the MLR calculation?
They're not included in the MLR calculation that is published in the annual report. That MLR calculation is a straight claims over premiums with no administrative costs included. We do provide in that report, though, each year the percent administrative costs associated with the plan, which is either 2.4 or 2.5% last year, not having it right in front of me, but that those costs would be included in that administrative component.
So thank you. Is the administrative cost then that we're paying to the carriers, is that included in the MLR, or is that part of the administrative portion?
Nope, that's part of the administrative portion as well, that 2.4, 2.5%.
Okay, so does a 2.4 or 2.5 include both then the administrative cost from the insurance company and the administrative cost in the comptroller's office? Are they combined?
It is combined, and there are some other costs in there as well. Actuarial costs from our actuarial firm, consulting fees, those types of things are also in there.
Can I ask what the logic is for not including the administration in it? I don't think that's standard in industry.
So when you look at sort of the and it actually has to do with sort of the ACA definition, right? The Affordable Care Act, when they defined medical loss ratio, which is sort of the most common way in which medical loss ratio is used, right? There are certain requirements or limitations, right? Minimum medical loss ratios that insurers have to achieve, and generally that is to limit administrative costs. So within that definition of medical loss ratio, it is just claims over premiums, and general administrative fees are generally not included. And so that is why we utilized an MLR that did not include administrative fees. But again, we make that clear in the report, and then list the percentage of the admin cost as well. So you can always add it back in.
I think we might need to follow up on that. I'm not quite sure that I understand how you're explaining that, because from the ACA's perspective, MLR clearly shows the amount that has to be spent on claims and the amount that can be set aside for administrative and profit in industry. So I'm not quite following why we would not be including it there. But I think that's probably a more in-depth conversation that we would need to have to get down to the ins and outs of it. But you did mention something that kind of leads me to my next question. You're looking at the MLR and the ACA in regard to insurance product, but in a recent PowerPoint that the Comptroller's office sent at the end of 2022, with possible changes to consider on slide 6, they went out of the way to say the partnership plan is not an insurance product. It is a state benefit provided to a non-state public employee by statute. So a state benefit provided to a non-state employee. Why was it important to point out that it was a non-insurance product, especially in consideration to the comment that you just made in regard to using MLR in an insurance specification?
So I think just 2 pieces. So highlighting that it's not an insurance product because it is a program that was put in place by the legislator and put in place, right, so that municipalities and their employees could benefit from the state employee plan, the administration of the state employee plan. The reason to highlight that it's not an insurance product is because we have to follow in setting the premiums for the program, right, we have to follow state statute, right? And it's the state statute that governs the plan, the partnership statute, and rather than the regulations that guide insurance products in the state of Connecticut. So there are two different sort of regulatory bodies, well, not regulatory bodies, but statutes that govern those two.
So that's interesting because this is an ASO plan. This is a self-administered plan, which is not subject to state regulation. So I guess but it's an insurance plan. It's an ERISA plan, basically, if it's a self-administered plan. So if it's an ERISA plan, it is administered by federal ERISA requirements. But you're saying, if I'm hearing you correct, and please correct me if I'm wrong, that this is actually a plan that is legislatively driven and not because it's an insurance plan. It's insurance. So I guess I'm not making the connection there. Why would
I guess
we
I'm not sure, Representative, I won't speak for Josh. I guess I'm not sure what your question is to us right now, or what we can answer for you with regard to that.
I guess how are you and I think we're this kind of was spiraling down. I'm getting more questions as I think about it, which would probably be best to formulate before I come back. But how are we saying that it is not an insurance product when it is an insurance plan that is offered to non-state employees? Are you saying that we're doing this legislatively? And for some reason, because it's legislative, it's not subject to the rules and regulations of an insured product?
I think what Josh was trying to say was that this plan was created by the legislature, but it is a self-insured insurance plan that our office does operate. And self-insured plans that are run by the state are not subject to some of the other regulations that other private plans are. So I don't know if that clarifies what you're trying to get at or not, but that's my perspective on it.
Yeah, I think we're just going down a rat hole here. I guess I'm just concerned that we're saying that this is not an insurance product when it's a clear insurance plan that's being offered to non-state employees, and is actuarially accounted for over the state employee and non-state confusion.
I wasn't the comptroller in 2022, so I can't speak to what that document was from. I saw my friends in CBIA were pointing to that in their testimony too, but I can't speak to what that presentation was or why it was phrased that way.
Okay. I appreciate that, Comptroller Scanlon. I appreciate your candor on that. It was 22, it was before you. But I think there's a lot of questions here. And as Representative Barry pointed out, I think an actuarial review is very different than an audit to ensure the soundness of the plan. But I'm going to continue to listen to testimony to see if I can find the answer to my question somewhere within it. Thank you.
Thank you, Representative. Any other questions from the committee? Representative,
Thank you. Thank you, Mr. Chair. So just a few questions and maybe a few off of what some of the answers that you gave previously. And I think I missed, first of all, you said audits have been done. So who has done or who regularly does those audits? I missed that.
So the Auditor of Public Accounts audits our agency and all the things we do, including the state plan and the partnership plan on an annual basis. So those audits are available to the public. But in addition to that, we on a monthly basis go before the Healthcare Cost Containment Committee and give information publicly about the utilization of the plan and what our MLR is on a monthly basis. We submit reports on a semi-annual basis to Open Connecticut, and every single vendor payment that we make is updated nightly on that website. But when it comes to setting the rates, we work with Siegel, which is a nationally recognized actuarial firm. They help us set our rates. They give us a projection, then they give us a second independent projection from a second actuary before we set our rates. So working with them, we feel like we have the confidence to move forward with what we do. And then we put out a plan or a report rather every January about what happened in the previous year in the partnership plan in particular. That's what I was saying earlier, Representative.
So the monthly, you said monthly you go over the MLRs. And is that information publicized anywhere?
Well, the meetings, I believe, are recorded, Josh. The Healthcare Cost Containment Committee are recorded.
The minutes are posted. They are not recorded, but they are open to the public. Minutes and agendas are posted.
Okay, okay, got it. So let's say, I'm just wondering, like, let's say July 2022 to December, has there been deficits with the medical loss ratios?
What were the months again, Representative?
Around, let's say around July to December. I'm just wondering what those were.
So I can respond to that. I think our most recent medical loss ratio for that time period, and we are, and this is a projection where you're projecting out the incurred but not reported claims, because not all the claims have come in from that time period yet. But based upon that projection, we're a little over 97%.
And I know we have talked about in the past some of the years where there have been deficits. So, and I know some have been discussed, and I'll have further questions about certain years, but let's say going back to 2018, and I know you weren't comptroller, but I believe there was a $10 million deficit, and I was wondering if you know where that money came from to cover that deficit.
So in 2018 and 2019, I was not comptroller, but the reason for the deficit was because of a regional adjustment issue that the legislature then passed legislation to correct. And we subsequently have not had any deficits related to that issue before, or since then, rather.
Can you explain what the regional adjustment issue was? I'm not sure I know what that means.
Yeah, basically, we were not able to sort of adjust for the differences geographically and the market in the state, excuse me, which was at the time particularly an issue in Fairfield County, where we weren't able to make the regional adjustments necessary to properly price the plans. And so we were able to change that through the legislature, and therefore that issue went away, and we haven't had that issue since then. Correct, Josh?
That's correct.
So where did the money for that deficit, where did that come from to cover it?
Anytime there is a deficit in the fund, it comes from the partnership plan fund itself.
So for those 2 years, that's where it came from?
In any year, that's where it comes from.
Well, except that I believe, right, I think it was this last year, I believe it was 21, right? There was 40 million. And I thought that was covered by ARPA funds. Isn't that what was used?
So no state dollars have ever been used to fund the partnership plan. The partnership plan is funded through member premiums. There was a one-time federal funding injection into the partnership plan, and that was as a result of the state basically saying during COVID to any state agency in the state, if you have costs associated with COVID, tell us what they were, and we will use ARPA dollars for that. This was truly the original intention of ARPA dollars. We had $40 million of expenses resulting from testing and treatment and hospitalizations that we submitted a invoice, I guess you could say, to the state for, and we received $40 million of ARPA funding. But outside of that, there's never been a state injection of funding into the partnership plan. Everything comes from premiums. So if there is a deficit, we then use the adjustment tools that we need to make to recapture that in the next year by changing the premiums.
Representative, I'm
Yes.
sorry to interrupt. Apologies. Can I make a friendly recommendation? Because I think that our questions are good and pertinent and important. I was wondering if we could maybe take some of that offline and
Sure.
stick to the adjournment of the bill.
I'll just ask one more then. Yeah,
Thank you,
sure.
ma'am.
So then I guess my only question is, my last one is, when it comes to timing wise, I think I have a concern as to, let's say a city sets its budget, right? And then if premiums are changed, are you coinciding with the timing of when budgets are set by cities? Because I know we've run into that in different areas up here at the Capitol where they're, city sets its budget. Then if you tell them, okay, your premiums are going to change next year, but their budget's already set, then they have run into issues. So is there anything being done to fix that and make sure that cities don't run into that problem?
Yes, I think we all learned a lesson in the last fiscal year when we and literally everybody else in healthcare got wrong what amount of utilization there was going to be in that post-COVID year of 2022. And so what we found was that, yeah, we rightfully frustrated some of our members by giving them a projection that was, a little bit off from where it ended up being. And so what we typically do is we give them projections, 2 different projections in the winter, in January, and then again in March. What we're now doing for towns is giving them a projection in November so that they have a little bit more lead time going up to their budget, that they can, decide whether or not the plan and the estimated premium increase that we're going to see is right for them and their community as they go into their budget process.
Okay. And just one last quick one. Sorry. Have you ever, let's say, used funds from the state employee plan to cover the partnership plan? Are those 2 separate accounts totally?
Josh?
They are 2 separate accounts and they're accounted for independently, and no dollars have been transferred from one account to the other.
Thank you.
Thank you, Representative. Any more questions? Representative Donucki?
I think most of my questions were probably answered by the interrogatory going on prior to this, but so we can safely say that not $1 crossed from one plan to another, and that there was a firewall to stop that from occurring. Is that correct?
That is what Josh just attested to. Yes, Representative.
So in addition, just to be clear, any possible deficits, not one penny was transferred between any of those accounts, and they were all kept strictly in their own silo. Is that correct? Not $1?
Yes, no funds have been transferred between those 2 accounts. I will say that to be clear for the committee, the partnership account is a sub account underneath the state employee account. But they are accounted for entirely independently, and they are 2 separate accounts with their own account numbers, and no dollars have been transferred between those 2 accounts.
So taking that answer just to follow up, and then I think I'll be all set here. So there's one master account that say would have everything in it, and then there's 2 separate accounts that's derived from the master account, so as to have the state plan, the retirees plan, and the partnership plan separately, or is that all drawn from one master account?
No, they each have their own account numbers and have their own account balances, and they are accounted for entirely separately. But from a sort of I don't know how do I want to state this, but in the structure, it is not a separate independent non-lapsing account. It is a sub-account within it. So it still has its own number. It's still accounted for 100% independently. You can follow all the funds that go in and out of each plan independently, and those are posted on Open Connecticut. But it is technically a sub-account of the state plan account.
So I've got to follow up again, only from the standpoint you described it. It almost sounds like there's one master account, and by auditing measures of some fashion, that's how you've got the three sub accounts, the state retirees, the state employees, and the partnership. And it begs the question of a hard firewall between the three accounts.
Representative, I'm not sure how many more times Josh can say that there's never been any sort of transfer between the accounts. It's something that we take very seriously, and they are separate. So the notion of a firewall, I think, would be if there was a reason for one, but we've never transferred any funding from one to the other, and therefore I don't know that there would be a reason for one.
Well, I thank you for your answers. Just an observation. It seems like even if there was an independent auditor, they could obviously prove that that was the case. If there's ever doubt or a question as to the validity of the information, I make that just as a suggestion as somebody who has had a substantial amount of municipal experience, and how independent auditors from time to time are a good thing. But again, good to see you there, and thank you for your testimony.
Thanks, Representative.
One more,
Thank you, Senator.
please.
Mr. Comptroller, it's good to see you again. My question is, when you do the auditing, and I'm not an auditor, I'm a healthcare provider. When you do the auditing, is it including all of the accounts at one time, and therefore the numbers look different than if you were to do them individually? And if so, what's the advantage of doing that versus breaking out each plan separately?
Josh, are you conversant enough in the APA's audit to answer the representative's question?
I'm not. I don't know exactly how they would look at it, but again, the accounts are have their own separate accounting streams. So the auditors would be able to look at each one of them independently. That is certain.
Yes, I understand, but would they be reporting them as individual, or would they be reporting them as all of one plan?
And I've not seen how they actually would report that. I mean, we report them individually. I can tell you that the Comptroller's office reports them individually.
Thank you.
Thank you very much. I believe that's it for questions. Mr. Comptroller, would you like to make any quick closing remarks?
No, just say that, Representative Nuccio alluded to the fact that, she and I had met, and we are more than willing to sit down and talk to anybody on this committee or in the legislature if they have questions or concerns about things that are going on. My door remains open to all of you, and look forward to continuing this conversation going forward and answering any questions that the committee has. I would urge all of you, if you have not, I know it's riveting stuff, but check out the partnership plan report that we published in January. And if there are questions that you have from that you don't feel like we're answering there, or things that are missing from that, tell us, and we can try to improve upon that for the next year. But I believe that you will find that to be very comprehensive. And then in addition to that, if you're really yearning for more than just a one-time per year thing, look at the minutes from the Healthcare Cost Containment Committee, and we'll give you the actuarial reports as soon as this committee meeting is over that we promised to one of the representatives earlier, so that you can dive into that. And my office is always willing to help if you have further questions.
Thank you, Mr. Comptroller. We appreciate your time, and thank you for the forthcoming report. Thank you again. Have a wonderful day.
Thanks, Senator. Thanks, everybody.
Thanks. All right, next we have Representative Comey's in the audience. Representative. Good afternoon.
Thank you. Thank you so much for having me. It's good to see you, everybody, a small but mighty committee here. I will just jump into my testimony. So co-chairs Wood and Cabrera and distinguished members of the Insurance and Real Estate Committee, thank you for raising SB 976. I am here today to talk to you about sections 35 through 37, which really confronts the out-of-pocket costs of the life-saving medication epinephrine. And this legislation caps the copays and fully insured plans here in Connecticut at $25. So for background, I am a food allergy parent with life-threatening allergies, and we don't leave home without this medication. We have a dual pack with him at all times and in many different environments, including home, members' houses, my school, family's houses, and schools. And in fact, my son, Michael, not too long ago, self-administered right here in this very building, followed by an ER visit. You know, epinephrine is the one and only first line of defense to counteract potentially fatal anaphylaxis. In Connecticut, we have approximately 353,000 people who have food allergy, and many more have allergies to bees, latex, and more. So I just want to briefly go back to about a decade or so to 2007, when Mylan, the manufacturer of EpiPen, which was the most popular and really single auto injector on the market, raised costs from $60 in 2007 to more than $600 in 2016. And in fact, consumers were outraged, and as was the Congress. And so in 2016, Mylan appeared in front of the congressional hearing for a 4-day hearing where she was unable, I should say, to explain the exorbitant reasons for a rise in costs and prices. So that really angered many lawmakers and citizens across the country, as you may know. So EpiPen has now been bought by a company, Viatris, and in 2022, they settled a class action lawsuit just last year over their anti-competitive practices for $264 million. Just a side note, as a food allergy family, for the past 16 years or so, we've received an invitation to join the class action suit. But unfortunately, we were unable because I found it actually impossible personally to estimate how many EpiPens we had purchased, for what price, and over what time periods. So we also did not have the receipts for all those years. Look, I'll just break it down that this life-saving drug is only costs a few dollars to make, and we're here at $600. There are some generics, but it is still cost prohibitive. In 2021, Rep. Williams, who had nut allergies.
Representative Comey, your 3 minutes is eclipsed. Please summarize.
Okay. In 2021, Rep. Williams, who had nut allergies, and I introduced this bill because of our mutual experience of struggling to afford epinephrine. As you know, many of you worked on this bill with me in 2022. We recommitted our efforts, and many of you here supported it and were with your blessing. We were happy to move it forward. We brought all the stakeholders to the table. We worked with the insurance industry, pharma, PBMs, advocates, and last year we passed this, as you remember, in the House with wide bipartisan support. So I'm grateful that you've returned this bill to, hopefully this will be the year to get it across the finish line. And I would be happy to answer some questions, and thanks for having me today.
Thank you, Representative. Any questions? Representative Wood?
Thank you for being here, Representative Comey. Good to see you, and thank you for all your work on this bill. I just wanted you to share with the committee and the public about the EpiPen that really everyone should have. It's the most expensive one, but it allows you to make the injection with accuracy. So can you just share that with us and what the costs are with that?
Sure. So there's a couple of really really great products that are on the market. We have the EpiPen, as you just mentioned. That is the classic auto injector where the needle, once into the leg as you need it, the needle will go back into the device so that no one is at risk of getting stabbed, after that's been injected. So that is the auto injector that has been around the longest, and is for a dual pack, it is $600, $650, something like that. And sometimes even a little bit higher depending on where you are. And so I also am a huge fan of what we have. I should have brought it along here to do a little demo, but we have the AviQ, which is a talking auto injector, and it guides the user into how to remove the cap safely, what experiences you may be experiencing, what symptoms you may be experiencing, and how long to press the pen and hold the into the leg. It is about this size, about half the size of my my phone here, and it's a great option for those. But thank goodness that some insurance will cover that. My insurance thankfully now does, but they can run up to $4,700 for a dual pack. Like they're just, and it's because the technology is so amazing as well. So, but they do, our companies do have, not coupons, but rebates that they work with customers with, because they want to ensure that folks can access and can carry it around wherever they need it.
And both of those pens you just described, those have a shelf life of 1 year, correct?
Absolutely. And in fact, I recently heard about someone and folks who will go to get to a pharmacy to pick up their prescription, and it would be for less than a year, the expiration date. So that continues to be a struggle. Expiration dates across the product line in over a variety number of years. So yeah, sometimes it doesn't even last a year, and then you've got to get a new one.
Representative.
And just to clarify, thank you, Mr. Chair, we passed this in the House, but it wasn't taken up in the Senate. Is that correct?
That's correct. We have passed it in the House last year. We had really wide bipartisan support, as you remember. And, I sat here on this committee and was part of that work. And it, fell to the calendar or something else. I'm not sure.
Would you know what the, I don't know, average copay is for, let's say, non-state employees or other people? Because you're asking to cap, right?
Right. So I don't have an average across the copay. I mean, obviously this is only going to, because the legislature only has authority over about 30% of our insured in the state. So this would be impacting fully insured folks and Access Health, certain individual and group plans. Some of our group state and Access Health state plans already, actually, this is already how much they pay, which is $25. So.
All right. Thank you very much.
Senator Anwar has his hand up on Zoom.
Oh, sorry, Mr. Senator Anwar, please proceed, Senator.
Thank you so much, Mr. Chair. Thank you, Representative Comey, for your advocacy. And I wanted to thank you for remaining steadfast to make sure that we save lives in our state. I just wanted to mention that there are not many medicines that are out there where in a matter of 30 seconds you would save a life. And Narcan is one and epinephrine is the other that is available. And Narcan, we are trying to make it easily accessible, but epinephrine, despite being one of the oldest medicine, remains even more and more expensive for people to be able to get. And then even to the point that sometimes the first responders cannot afford it, whose job is to be able to save the patient. So we hear you, I hear you loud and clear, and then I'm sorry that we have to keep bringing this again. And hopefully this time around, we will make sure that we pass this bill And I wanted to thank you. So thank you for allowing me to comment, Mr. Chair.
Thank you, Senator. Any other questions or comments? Thank you, Representative.
Thank you. I would just like to mention that there's one small addition on the bill, which was the PBM part, which is really our way of expanding sort of access to it. So broadening out the impact. Pharmacy benefit managers must offer an epinephrine auto injector, whether generic or name brand, on their lowest tier formulary. And that is something that when we worked with the advocates, when we worked with the insurance companies, when we worked with the PBMs and the pharma companies, that was something that they brought to the table that would, that, you know, they became part of the solution. And I just want to thank, you know, those folks for being open, for coming to the table with us and helping be a part of the solution. So thank you.
Thank you, Representative. Thank you for your time today. Going to toss over the chair to my very capable co-chair, Representative Wood.
Thank you, Mr. Chairman. Senator Berthel, followed by Samantha Dill.
Good afternoon, Chairman Wood, Chairman Cabrera, Ranking Member Huang, Ranking Member Pavlik D'Amato, and distinguished members of the Insurance and Real Estate Committee. I am State Senator Eric Berthel. I'm testifying today in support of Senate Bill 976, an act concerning healthcare coverage mandates for certain health conditions. I am specifically here to advocate not, well, of course, for the whole bill, but specifically for the section regarding treatment of obesity and providing insurance coverage. As a recipient of bariatric and metabolic surgery myself, I can attest that it is an effective and life-saving procedure. Obesity is a health crisis in our nation and state, and the surgery has a proven track record of improving many conditions that are associated with an individual being overweight. These health-related conditions include, among other things, type 2 diabetes, heart disease, stroke, and high blood pressure. Currently, most insurance plans in the state do not provide coverage for bariatric and metabolic surgery. The coverage is currently available to Connecticut residents who are covered by our state Husky plans. We've introduced this bill a number of times in the past. We made some forward motion last year, but it is absolutely beyond time to get this legislation passed. There is ample scientific data to support the efficacy of life-changing outcomes from metabolic and bariatric surgeries. Improving the quality of life via proven medicine should always be a priority. There is also ample financial data via health insurance companies to demonstrate that investing in metabolic and bariatric surgeries reduces the future cost of healthcare expenses. This includes many of the comorbidities associated with obesity. It is easy to understand how an investment in a life-saving surgery today offsets the often high and long-term expense for debilitating illness and diseases in the future. Bariatric and metabolic surgery should be considered an essential healthcare benefit in our state, as it helps individuals live longer and healthier lives. Many individuals will not be required to take as many prescription medications once they receive the surgery and lose weight, which lowers healthcare costs in the long run. All healthcare insurance should provide coverage for metabolic and bariatric surgeries. I respectfully ask the committee to look beyond the expense of doing this and instead at the tremendous change in the quality of life for these patients. I am a living witness and proof to this. The overall savings that will come from reducing and eliminating the comorbidities associated with obesity are worth investing in today. I urge you to pass this bill. Thank you, Madam Chair.
Thank you, Senator. I wanted to ask you, I see a bunch of these companies, Awaken 180, New York Bariatric, running ads. I hear it on the radio. I see the billboards. Are all of these operating with no insurance coverage, or are some accepting insurance? I was just wondering because I see them expanding.
So, Representative, thank you for the question. There has been a prolific expansion of bariatric surgery providers in Connecticut. They are most likely accepting insurance where it's available, but I can tell you from having been an advocate and kind of a mentor, if you will, for people who are thinking about this surgery, that People will mortgage their homes to get this surgery if they're private pay, if they don't have coverage. I would guess, not knowing exactly some of these providers that are outside of our hospital systems, maybe they're providing financing. I don't know, but it is so life-changing and so profoundly effective that people are willing to go and put their houses, if you will, or drain their savings account to have this surgery done.
And can you tell us a range of what it would cost today if you had private pay that didn't cover this, what the out-of-pocket expense would be?
Yeah, I can tell you that in 2019, my surgical procedure was covered by health insurance, but the initial billing was about $70,000. Yeah.
Thank you.
Thank
Any
you.
further questions? Senator Wong.
Thank you, Madam Chairwoman. Senator Berthel, thank you very much for advocating, as you have for many years. Having seen you in the House and seen the transformation of your surgery, I think you've taught me so much, but could you share with the committee that this was a health decision, not a cosmetic one, but a health decision that was precipitated by concerns? Can you share what led to your decision and your rationale to have this surgery?
Sure. Thank you, Senator. I appreciate the question. This is certainly not about cosmetics or aesthetics or looking good in front of a mirror. That may be one of the ultimate positive side effects of this. For me, at 47 or 48 years of age, I was hypertensive. I was pre-diabetic. I was turning my legs to get out of bed in the morning and had pain in my knees and my ankles. And 5-6 years later, I've managed to keep about 130 pounds off of my skeleton. So some of you have reacted in surprise to that. I'm not the smallest guy in the world today by any measure, but I can tell you that all of those things that that I was suffering with, or was looking down the barrel of a gun, if you will, that was about to affect my life as I approached 50, have all been removed at this point, which is amazing. It's absolutely amazing. You know, that you and I don't, the only medication that I take every day is a vitamin, right? Where I would have probably been on high blood pressure medication and maybe insulin dependent. And if you look at the cost associated with that, and I know, Senator, that wasn't necessarily your question, but I think it's part of the discussion. If you look at the cost for one individual to be on hypertension medication for the rest of their life, okay, and all of the associated comorbidities of hypertension, the things that happen where they could have a stroke or a heart attack, the investment Representative Wood of $50,000, $40,000, if you look at what insurance actually pays, versus a lifetime of those medications and the comorbidities and the quality of life. You know, Senator Huang and I spoke years ago about how I wouldn't go outside and toss a football with my much younger kids at that point, because I was afraid I might fall down and hurt myself. Right, when I was morbidly obese and a lot larger. And that all goes away. It all goes away. And I can tell you that there are some that will say, why do we have to perform surgery? Why do we have to pay for people to stop eating? Just stop eating. Stop doing it. Stop shoving food into your mouth, right? It's so much more. Obesity is a disease, is classified as a disease by the Centers for Disease Control. And I'm guessing Senator Anwar probably has his hand up because he has been an advocate as well and has supported this legislation in the past. This is making profound changes in people's lives. It's not about putting on a smaller shirt or pair of pants. It's about changing lives and giving people their lives back.
And I wanted to follow up on that. I mean, I think there may be, and you've been a tremendous advocate, but it's important for people to note that obesity is not a personal decision. And people kind of say lack of willpower and all that, but there are medical conditions and it is a medical condition. And I think the recognition of that is another integral part of this consideration. But I also want you to be able to share that it is not an easy way out to managing your body weight, because you continue to be disciplined to manage your diet, to watch what you can or cannot eat. I think one of the examples you say is about carbonation, how it doesn't work. So it's a reflection of a body health decision with the surgery as part of the continual process of maintaining your health and maintaining your weight. Please share briefly, some of the considerations. So it's not an easy out.
Yeah.
It is a continual, lifelong effort to be able to maintain your weight and your health.
Thank you, Senator. I believe the best way that I could summarize this would be as follows. And I believe you'll hear testimony today from Dr. Ben-Brahim, who was my surgeon. He said to me when I had a first consultation with him that this is not an automatic fix. This is not a magic pill that you'll take. We're giving you a tool. We're giving you a tool to use that will help you, but you have to be committed and you have to manage this. Some people will say, the experts, certainly far beyond my ability to speak to this or knowledge, that obesity is not unlike an addiction to an opioid. That it's and the difference being that we can go to any fast food restaurant wherever you want. And you could sit down and eat a 10,000 calorie meal if you want. No one's stopping you from doing that. If you have some dollars in your pocket, you can go and eat whatever you want. Where maybe access to opioids and or illegal drugs is not the same. It doesn't come with the same ease, but the addiction is considered by many mental health experts as even more powerful than the one that comes from some of those illegal drugs. So it is an ongoing daily routine to manage this process after the surgery. The surgery is the first step and the tool that is given to help you control future weight gain.
Thank you, Madam Chair, and thank you for your leadership and awareness of this and
Thank you,
helping
Senator.
raise awareness. Thank you, Senator Brithell.
Thank you, Senator. Thanks.
Thank you very much.
Next up, we have Samantha Dill, followed by Susan Halpin. I'm sorry, followed by Michael Gassa. Actually, I'm wrong again. Samantha Dill, you are correct, followed by Randy Calabrese.
Hi, thank you for letting me speak today regarding SB 976. I'm asking for your support with the added coverage for PANDAS. I'm a mother of a nearly 15-year-old daughter diagnosed with PANDAS. In 2021, our world turned upside down. My sweet, caring kiddo, who was a competitive gymnast, a dancer, and raced soapbox derby, was suddenly riddled with a cascade of new symptoms we had never experienced before. It was started with a slight head tilt tic that progressed to all sorts of tics, head movements, verbal tics, and full of random sounds. She started having restrictive eating due to intrusive thoughts. She was worried her food was unsafe, unclean, or that she might choke. It wasn't that she didn't want to eat her favorite foods or drink her favorite drinks. Her brain wouldn't let her. Then the OCD and rage started. Her beautiful handwriting was gone and now nearly illegible, as well as her math skills. She started having seizure-like episodes and hallucinations. She saw and heard things in her mind that I wouldn't wish upon my worst enemy. She was sleeping up to 20 hours a day, in constant pain and in and out of touch with reality when she was awake. Any spark of joy from her eyes was gone. Over the last year and a half, we've spent over $15,000 treating her, following doctors' recommendations as best as we possibly could, despite not being able to get IVIG for her. We waited and prayed that one of her specialists would be able to push insurance to get it covered. She was on antibiotics, anti-psychotic medication, anti-inflammatories. She'd had over 10 anaphylactic reactions with unknown causes in a year and a half. Treating her became a full-time job. It required 2 adults at home at all times, one solely to care for her and the other to care for her siblings and our household. I worked evenings and weekends while my fiance was home during the day. And at the worst of times, my parents would come and take time off from work so that there was always 2 adults at home. Families like ours are often left in financial ruins just to try to heal their child and bring their child back to them. Well, just last week, she was able to receive her first IVIG after waiting a year and a half through torment. Even already, I can see glimmers of my energetic child and happy and come back. Today, she's sitting here. Normally, she would be in bed at home. So I'm asking to please support this and help kids like her get the care they need. Thank you.
Thank you so much for sharing your story. I'm just, really hit me. Why did it take 1.5 years for you to get the treatment that you needed?
The first doctor that we saw recommended IVIG from the start. He could not get insurance to cover it and told us we had to see a specialist in New York. The specialist in New York was $5,000 out of pocket with an additional $6,000 to $10,000 in testing. And that testing was hopeful that it would then have insurance approve IVIG. We couldn't afford that. So the other specialists we saw, we had to go through trial and error in order to get insurance to try to see the benefit of the need of it. We had tried antibiotics. We had tried, I don't know, I can't even count how many medications she's been on over the last 1.5 years, just to go through this cascade of, we tried this, it didn't work. We tried this, it didn't work, for then insurance to say, okay, we'll cover it.
Thank you for sharing the story, and thank you for bringing your family. And it's so wonderful to see your daughter and her dog here, today. It really is important that you guys came out.
Thank you.
Any questions? Representative Pavlik-Tomato.
And, thank you also for sharing your testimony and your story. Can you just explain a little bit about IVIG? I know it was the other woman went into a little bit, but I'm still unclear as to what exactly it is.
So it's immunoglobulins from thousands of people, and it's an intravenous monthly infusion. So it's supposed to help reset the immune system, to the best of my knowledge. I'm not a doctor. I just do what they tell us. But it's supposed to, because it's an immune response, it's supposed to help reset her immune system to fight what it's supposed to fight instead of fighting her brain.
And is that the most common or effective way to treat PANS at this point?
That's what we were told after you've tried other things. For some kiddos, if you catch it early, antibiotics work and things are great. For her, we've tried everything.
Thank you very much.
Thank you for coming. Next up, we have Randy Calabrese, followed by Michael Gossett. Okay, we'll do Michael, followed by.
One moment, she's logging on.
Oh, sorry. That's a remote person. Yep. Is Randy on?
I am on. Can you hear me and see me?
Yes. Yes, we can.
Perfect. It just had to transfer for a moment. Thank you. My name is Randy Calabrese. I am a mom of a child with food allergies here in Connecticut. We have 3 kids actually at home and and neither of the first 2 had food allergies. So now our daughter is 4.5. She was diagnosed with food allergies through an anaphylactic reaction at 5 months old. Prior to having a child with food allergies, I would never understand fully why we actually need 2 epinephrine auto-injectors or 2 doses of epi. And I think I really want to hammer that home with you all, because we've had several instances where our daughter has been hospitalized for anaphylaxis. And on those occasions, she's actually needed sometimes 2 to 4 doses of epinephrine. As an attorney in this state, I sometimes have to measure my life in 6-minute increments. As a mom of a parent with food allergies, I have to measure my life in 5-minute increments, because sometimes you need to have another epinephrine dose after 5 minutes. So wherever you go, you're always measuring, how far am I from a hospital? How far am I from an ambulance? How long will it take for them to get to me? Because you need to have as much epi on you to be able to administer that every 5 minutes at times, depending on how severe the reaction is. This past week, I administered a dose of epinephrine to my daughter, and we were off in the ambulance to the hospital. At that point, if you only have 2 on you, you now are in a position where you better get another one quick. The cost of these epinephrine injectors is exorbitant. I do second what had been said before about AviQ and how the ease of use really is helpful. And some of these auto-injectors vary by price, but as a person who pays upwards of $40,000 to $50,000 for health insurance as a self-employed individual in the state, we are still faced with copays that are sometimes more than $300 and sometimes up to $600. As a parent who has a child with food allergies, you need to have 2 doses of epinephrine at your house. You need to provide the school with 2 doses as well, and they have to be closed. So you can't even recycle what you have. Although many people, I guess, are getting some auto injectors that are lasting a year, we are typically seeing times when we go to the CVS or Walgreens and we're picking up epi that expires in 6 months. And so you are faced as a parent with several instances where you have to replace an EpiPen, and that could be you've already administered one, so now you need to get another one, or it's expired, or heaven forbid, it's exposed to some extreme heat or cold. And extreme heat or cold with EPIs is actually really not that extreme. It's a very small window of heat and cold tolerance that they have. Sometimes you're in a position where you've administered a dose of epi as a parent. And I should add, by the way, obviously I'm sitting here and talking to you, our daughter is okay after the last dose of epi, but you get an ambulance there and they only have one dose of epi on the ambulance themselves. I think some actually don't, and my
Andy,
understanding
your
is
3 minutes are up. If you could just summarize, please. Thank you.
this is a life-threatening condition that affects so many people, including children. There's no reason that this should be cost prohibitive for someone to have an EpiPen on them at all times, and actually too. Thank you.
Thank you so much. Any questions from the committee? Do we have any questions on Zoom? Randy, thank you for your testimony today. Michael
Thank you.
Gossett, followed by Sue Halpin.
Good afternoon, representatives. Thank you for this opportunity to speak on this bill to increase the penalty for driving without insurance. If any of you have lost a loved one due to the actions of another person, you'll understand my purpose for being here. My name is Michael Gossett, and I've lost both of my parents in separate incidents, 40 years apart, to drivers under the influence. The car my mother was driving was hit by a drunk driver, and my father was driving when another motorist fell asleep at the wheel and hit him. We suspect that the driver who fell asleep was under the influence, but that is not why I'm here. I'm here because neither of the motorists possessed auto insurance at the time. This means that our family was not able to receive any type of settlement to assist in their recovery with medical bills. Though we cannot put ourselves into the mindset of another individual, the drivers obviously felt that it was no big deal to drive without insurance, or perhaps just this one time. Well, if those drivers had not been on the road, my parents would have led a more productive life. I know mine was changed forever. The reason those drivers were on the road and ultimately destroyed lives was because they disregarded the law. If the law were stiffer, one would hope that they would have thought twice about driving. I asked the committee to implement this law to save lives. I hope to God that you nor your family are on the receiving end of an automobile impact from an uninsured driver. Thank you.
Michael, thank you for sharing that very difficult story with us. Any questions from the committee? Thank you.
Oh, one final comment. Is that right? I did see that for a commercial driver, there is a penalty of prison time. For a non-commercial, there is not. Okay, thank you.
Thank you. Susan Halpin, followed by Wyatt Bosworth.
Good morning. I think morning still. No, good afternoon. Sorry. I'm Susan Halpin. I'm here before you today as the Executive Director of the Connecticut Association of Health Plans, representing Aetna, Anthem, Cigna, Connecticut, and United Healthcare. It's really a pleasure to see you all in person again after a few years hiatus. So thanks for having us and for being here. I'm here today to testify on really 3 bills. I've supported written testimony on a couple of them. It's nice to be here in support of a few bills before this committee, Senate Bill 437 and HB 6619. Unfortunately, we are in the position where we have to oppose Senate Bill 976. I'm going to focus the majority of my remarks on Senate Bill 437, which is an act requiring the audit of the state healthcare plans, namely the partnership plan. We have been before you for several years now, under different titles of different bills, from sustenance to public option. All had the central theme of being basically a buy-in to the state employee plan, or its offshoot known as the partnership plan. And I think it's really important, as I listened to the questions that the committee had, to say that the partnership plan is really a unique animal unto itself. A similar plan does not exist anywhere that we are aware of, at least in this area. And throughout the debate that we've had over the past several years about public option, about sustenance, about state employee buy-in, about MEHIP, all of which this concept has gone by, there have been so many questions that have been raised, which heard many of them articulated here today. Questions about stability, sustainability, solvency of the partnership plan, how private plans would be treated under the same scenario. We, along with the business community, have long held that there's an unlevel playing field that exists with the partnership plan. They are not held to the same regulatory standards that the private carriers are. They don't have to go through rate review and approval by the Department of Insurance. They don't have to have the same reserve requirements that private carriers do. They don't have to pay some of the same fees and assessments that the private carriers do. They also have the ability to lock groups in for 3 years at a time. And then charge a penalty on the way out the door if a town or a group decides to leave. Private carriers cannot do that. There have been reports, as Comptroller Scanlon reported, several reports, in fact, that have been issued from time to time. I think they've all raised.
Susan, your 3 minutes are up. Please
Sure.
summarize.
Sure. I think they've all raised additional questions. And I think to be fair to the remarks that were made earlier today, that an audit would simply perhaps verify what has been said. So I hope that you all are able to put that bill forward and see it through to passage. And we thank you for your time today. Happy to answer any questions.
Thank you, Susan. You are representing the carriers in support of the audit against the mandate bill. What was the bill that you are also in support of?
In support of the pay for delay ban prohibition.
And why is that?
The cost of pharmaceuticals continues to be an escalating portion of the healthcare dollar. I think even the governor referenced in his proposal last week, the year-over-year increases in pharmaceutical costs, now upwards of 22 to 25% of the healthcare dollar. The FTC actually, in preparing for this testimony, I got on their website, and it's really interesting to see that they are taking action on these types of programs whereby pharmaceutical manufacturers are paying perhaps a generic manufacturer not to bring a lower cost alternative to market. And I know Sam Hallemeyer is going to testify later in the day, and he has a lot of the expertise on this that he can share with you. But I commend the committee for raising it and for starting the conversation about it, because I think too often we focus on the cost of premiums when we need to be looking at the underlying cost of care that drives the premiums.
Yeah, thank you for that. We're excited about this bill as well. I know our friends at AARP will hopefully be testifying in its favor. Do you have any sense of what kind of savings this bill, if passed, would put on the pharmaceutical costs? If it is 20 to 25% is the average increase per year, what would we be hoping to save, or is there any sort of data available from other states that have passed this?
I can just share with you that according to an FTC study, the anti-competitive deals cost consumers and taxpayers $3.5 billion in higher drug costs each year. And that's a figure right off of their website. So I don't have the Connecticut specific numbers, but certainly I think that's a compelling figure to work with.
Yeah, it truly is. So we're talking about cost,
Mm-hmm.
but I also think we should be thinking about people who are being delayed in getting access to these drugs as well. So there's, sick people out there that are hoping that these could get to the market faster too, that are waiting for trials. So there's that, component of this that I hope we explore as a committee as well. So thank you very much. Any other questions? Senator Wong.
Thank you, Madam Chairwoman. Welcome, Ms. Halpin. You represent the health plans in this testimony.
Correct.
A question, do all of your health plans that operate in the state of Connecticut go through an audit process through the Department of Insurance?
Well, I think as one of the previous speakers said, they said only 30% of the market is subject to a state regulatory authority. If you look at the percent in the context of the whole state, it's about 11%. It's 30% of the fully insured, 30% of the commercially insured market. That 30% goes through rate review at the Department of Insurance, which is a really important aspect that they go through, with a fine tooth comb about what the rates are going to, whether they are actuarially sufficient, whether they're not too high or too low, frankly, because what you don't want is to have a carrier come in and, lowball the premium rates, buy up the membership, and then not have the ability to pay the claims on the back end. If you're talking about the self-insured market, I would say those are the employer's dollars, right? They belong to the employer. The employer is watching that very closely, and Wyatt from CBIA, who's going to testify a little bit right after me, can speak to some of the new responsibilities that employers have with respect to self-insured plans. The big difference between those plans, the fully insured plans, and the partnership plan is really that it's government and taxpayer dollars, right? It's, if you run over in a private self-insured plan, maybe you have a stop loss policy, or you have to reach into the other bank account to fill up the claims bank account. The questions I think you all raised earlier today is what happens when there isn't enough money in the bank account for the partnership plan, and where does the money, come from? And I can't say that I know. I've read certainly different things, seen different reports, and, have been lobbying this issue for, over a decade. So, it was very encouraging to see the committee, raise a bill like this to look at all those aspects and get an answer that is, signed off on, frankly, by the, a actuary who is a member of the American Academy of Actuaries, because that's a really important distinction. When an actuary signs our rate filings at the Department of Insurance, they're basically putting their license on the line, that everything that is in there is factually correct. And I think that's the standard that you have to have in the information when you're looking at these accounts as well. I know there's been talk of, actuaries signing off on them. I'm not sure whether those folks are members of that academy with that strict certification standard.
What do you say for people that look at different programs and looks like a health insurance program and acts like a self-insurance program, but from an administrative side says, I'm not a health insurance policy. And you as a representative of the health plans and the insurers have to compete against that. What's your thought on that? I mean, what would your commentary be to bring it in line from a transparency standpoint, which you have to subscribe to, leveling the playing field?
Right. I mean, I think you hit the nail on the head, right? That has always been the concern. I think the carriers welcome competition. The folks that I represent, they may work together on the association, but they are fierce competitors in the market, and they are happy to compete on a level playing field. I think what happens with the partnership plan is that it's, as I said before, an animal unto itself. right? There are certain rating factors, for instance, in the small group market that the carriers have to utilize in determining rates. They're very narrow, right? You can only rate your entire pool of small group, not just, Joe's Garage here or, Aviance over here or whatever. You have to take the whole pool and you can only rate them on basically 3 factors, right? You can rate on age, you can rate on family size, and you can rate on geography. And then you put it all in the mix master and you come up with a rate. When we look at we're not quite sure how the rates are determined, for the partnership plan. There's some combination there with the state employee plan where there's an overlay, as far as I understand, of how the rates are decided in that broader pool. But I think those are some of the questions that you'd have to have answered. Again, the premium tax, if we had MLRs, if the carriers had MLRs that were above 90% and close to 100 or over 100, I can guarantee you that the Department of Insurance would be taking action against that carrier, bringing them in for financial review, monitoring daily what our financial reserves were up against our anticipated claims, because at the end of the day, they want to make sure that the carrier has enough money to pay the claims for its members. So I think that's the crux of it right there, right? Which is, the standards that private carriers are held to compared to, the partnership plan.
Thank you for your insight. Thank you, Madam Chair.
Any further questions? Representative Pavlik Tomato.
Thank you, Madam Chair. And I know I believe it was the comptroller who, maybe it was Josh, who said they were at 97%. And I guess I would assume that there are some outstanding claims that still have to be paid because we're only mid-February. So when you're talking about a 3% difference there, I would assume that it's going to go over. So 97% for me at mid-February is basically they're going to be running at a loss. And I did go onto the comptroller's website just to look at the meetings that he was talking about, which I'm grateful for, but they're kind of general, don't really break down anything when it comes to claims or medical loss ratio, those numbers. And it's 1 page, a few lines. So, I am interested in getting those numbers going forward from him. So, but if there's anything else, I don't know if there was anything else you wanted to add as far as any of the bills.
Well, just in terms of what you were saying about outstanding claims, we call that IBNR in our world, incurred but not reported. And it's like having your credit card and you don't have a balance due this month, right? So you say, oh, I have 0 debt, but next month, you put $5,000 on and you're going to owe that by the end of March. Claims work the same way. Providers have, I think it depends on the situation, but 30 to 60 days and sometimes longer to submit a claim for payment. So, you have that tail always that you have to be prepared to fund going down the line. So I think you're right. You can't just look at a snapshot in time on a month, although that's an important stat to look at, but you also have to look at the incurred but not reported figures in combination thereof.
Thank you.
Representative Denning.
Thank you, Madam. Good afternoon.
Nice to see you again.
It's nice to see you here again. All of your companies made money last year, correct, that you represent?
Yep.
What do you think it would cost? And I understand your concern is the act concerning healthcare coverage mandates. Could your companies afford EpiPens for those people who have used them historically in Connecticut? And I understand why you may not want to pay for bariatric surgery because of the expense, but what could we say this has to be taken care of because it's quick, it's short, and it would resolve the problem?
first, I would be hard pressed to find a company that didn't cover an EpiPen. I always hesitate to say that, but I am the parent of a food allergy kid. And my son outgrew the allergy at 21 years old. So I know the EpiPen trials in a very personal way. And my carrier was always, always covered the EpiPen. I think the question is, why does the EpiPen cost what it does today? Right? I think we're focusing on the wrong piece of the puzzle. If we cap the copay, for instance, on an EpiPen to say $10, that does nothing, absolutely nothing to address the actual cost that the carrier is now being asked to cover. So those things do build in. So I think it's the unintended consequence of some of these proposals that we have to be very much be concerned with. And Representative Comey is correct. We did work with her on that legislation last year. We need to look at it in the context of this entire bill today, which includes a lot of things that I would be hard pressed to say we don't cover. Certainly there are things we don't, but it's a matter of what are people prepared to pay for in their premium. And like I said, we go through a rigorous process of rate review and approval with the Department of Insurance. While you may see some of the big numbers thrown about in terms of profits, the typical profit is anywhere between 3 or 5%. I think if you looked at any pharmaceutical company or others stakeholders in the healthcare delivery system, you would see margins significantly higher than that 3 to 5% profit margin.
Thank you. I, as a nurse anesthetist, I gave epinephrine daily. And it was the cost that I'm hearing for EpiPens of $700 is outrageous when I would pay pennies on the dollar for it.
Yeah.
And if you want to charge, if you want me to charge $650 to draw it up and give it to you, that I wouldn't complain about that, but that seems unreasonable also. So I appreciate your comments and thank you.
Thank you.
Representative Delnicki.
Thank you, Madam Chair. And thank you for coming forward here. You made a comment and I want to just probe a little bit more about your opposition to 976 and specifically bariatric surgery. I speak from having friends that have had that surgery that are off meds that they no longer need to take that were a substantial cost. And we've heard from a colleague of ours about how that basically, I think, saved his life or restored a level of quality to life that he would never have. Likewise, my friends that have had it, they would never have that quality of life, and they're going to avoid having to have diabetes, onset diabetes, and things of that nature, which in and of itself has a huge cost. And I would dare to say probably above and beyond what the initial cost of the bariatric surgery would be. So my question to you is, how do you justify being in opposition of something like that, that quite frankly can save a substantial amount of money over the course of a person's lifetime and in essence pay for itself versus not wanting to or not seeing it covered?
Thank you for the question and I appreciate it. I think my first response would be to say that the bill before you includes much more than bariatric surgery mandate, right? It's an enormous bill that has over, a dozen, new mandates. And I feel your pain sitting up there. When you look at it all in one bill, I mean, it is enormous. I think when you look at it as a policymaker, you have to remember that if you pass these mandates, they apply to a very, very small portion of the entire market. And what's happening in the fully insured market is people and companies are moving over to the self-insured market for added flexibility, perhaps not to include these mandates. But I will say one other thing from a carrier perspective. The carriers are not static. right? They're reviewing new benefits, new procedures, new drugs all the time. And looking at the benefit analysis as things grow and mature and change procedures. There are many plans that do cover bariatric surgery. You know, those things do happen and evolve over time. But when you put all of these mandates in combination on a small employer who is not required by law to provide health insurance and is struggling to afford the premiums for health insurance, I think you probably do more harm than good when you add additional mandates. And take, for instance, you know, the health insurance exchange. That, you know, I think it's one of the reasons why we would very much support a mandate review process before a mandate, you know, went into effect. So you could see what the cost of each mandate is before it goes into, is implemented. And so if you have the exchange, which is a fully insured product, right, heavily subsidized by the government at the lower income levels, the more that cost goes up as a result of mandates and other things, the less valuable the subsidy is that person is getting as well. So premium goes up. Now the subsidy only covers, you know, 75% instead of 90%. I'm sure I don't want to say that it is not going to save money down the line. But when you're looking at the costs year over year, and I think you heard Senator Berthel, who I have great respect for, say it costs $70,000. That's a significant amount of money, you know, in the course of 1 year. So again, you know, I think if if the committee wants to move forward with a lot of these mandates, there has to be a recognition of what it's going to cost in the premium. And when you see those rate increases, you know, annually at the Department of Insurance, have to understand what is going into those rate increases. And some of that is mandates as well as trend, et cetera. But
So I'm going to ask a follow-up to your commentary there. And I
sure.
thank you for your explanation. So somehow you have to balance the long-term savings with the bariatric surgery. And quite frankly, that's a very easy one to demonstrate the cost savings and cost avoidance. I watched my mom go through old age diabetes and how tragic that can be and how it can affect a person's life. And quite honestly, if she had had bariatric surgery, it would have made a huge difference in the quality of her life. She probably would have lived quite a few more years than she did. But the point being, perhaps you need to take a look at individual mandates. And yes, this bill is very encompassing. And it covers a myriad of issues. But something as straightforward as a bariatric surgery, it seems to me that's a home run, both in the short-term cost versus long-term savings. And I would say that something like that would make a tremendous amount of sense. My observation.
Sure. And I appreciate your observation. You know, I think our role is to explain to policymakers what the implications of various pieces of legislation are. And on an annual basis. And I think you've attended some of our rate hearings in the past, if I recall correctly.
Yes, I have.
And so, you know, yes. So, you know, the exercise that the, you know, health carriers go through. You know, if in your wisdom, you look at all the data as policymakers and you make the decision that this is a, you know, has the benefit in the long run of passing, I would just ask, you know, that folks acknowledge that when you see the premium increases on the other end of the equation. You know, I really am here just to kind of give you the sense from the industry of what these things look like. If the legislature passes them, you know, the carriers will price them. That is the equation. And there may be savings, you know, certainly farther out, but that's going to accrue down the line and not in that individual year where you're bringing forth a premium increase as a result.
Just one final question. So how do you quantify the savings in the future? Because that is probably the one thing that would make the surgery from a cost benefit, not a person's quality of life, because we know it improves the quality of life. How do you approach the cost benefit analysis when you know that there's a number of issues that you're going to avoid in the future, 5, 10, 15, 20 years down the road?
And I would have to defer to an actuary on that, which I am not. But what I will tell you is, I've been with, 5 different plans over the past several years, 5 different health carriers. So what savings might accrue with something like that may not accrue to the plan I'm in on that day. And again, I have to stress over and over and over again, 70% of the commercial market is self-insured and therefore would not be bound by these mandates. I get constituent calls all the time when something passes here at the legislature and they say, "What, my insurance company is not covering it." And my response is, are you in a self-insured plan or a fully insured plan? Because the self-insured plans do not have to pick up those mandates, including the state employee plan and the partnership plan. Do not have to pick up any of the mandates that you pass. They may do it. They may have done it in the past on a voluntary basis. And Comptroller Scanlon may choose to continue to do that, but there is nothing to say that a future comptroller is required to pick up every mandate because the state is at present a self-insured plan.
Thank you for coming here today, and thank you for your responses, and thank you, Madam Chair.
Thank you. Go ahead.
Thank you, Madam Chair. I do recognize the limitations that we have. And I have done many bariatric surgeries. And if we are going to mandate, we should at least consult with the medical profession to determine at what BMI level, which is what I think they determine these surgeries by, that we would mandate it. Not that we would encourage people to eat more so that they could get the surgery, but there are people who are using and abusing this surgery where yes, it's an illness, but they do not have the health complications and risks yet. They are doing it more to prevent that from getting there. And I struggle with that myself. I will tell the committee that anytime you see a health center pickup that only does one thing, like a bariatric center or an orthopedic center or an eye surgery center, there is money that is being made. And it's probably, some of it's probably being abused. So I think the mandate, I love the mandate review recommendation. Thank you.
Thank you.
And just to remind the committee, we do have a raised concept on the mandate review. So we should, anyone interested in that, please follow up. I have one follow-up question, if you don't mind. I'm sorry. Should we be worried about passing mandates that cause, or is there any data that points to people coming onto the fully insured market to benefit from a mandate for signing up for a year and then moving off the plans? I know that Connecticut is a very mandate rich state because I've been to NCOIL and other conferences, but are we encouraging people to essentially sign up for a mandate for a year and then going off the plans?
Thank you for the question. I think you certainly see that in the individual market. I won't say it's mandate specific, but when you have rolling open enrollments, people follow the financial incentives. So if there's an ability to enroll, say, in the fall, in the winter, say your profession doesn't require you to be working 24/7, in the winter, you're working in the summer months. You enroll, you get all the surgeries and all of the, other treatments that you need, and then you disenroll and you no longer pay the premiums. And then you can come back the next year and do the same thing. I think we call that churning, and you certainly do see that. Particularly in the individual market. I can't speak to the commercial market. I think most employers are struggling currently to just be able to provide health insurance. I think the one thing we forget oftentimes about health insurance is how it started. And it was an employee recruitment and retention plan. Just like you see now, my firm provides pet insurance because that's what, employees want, right? They want those added benefits. And so employers have a hard time not offering health insurance because they need to offer it in order to recruit and retain employees. And so they're looking to provide, I think, the best coverage that they can for, their employee size. But what you do see is, with increased cost sharing and deductibles and other plans, you see more employee share in the cost as the premiums get higher, which I know you hear a lot about. Likewise, you see a migration, a pretty significant migration into that self-insured market where they can tailor the benefits more specifically to their own employee base and not have to cover all of the mandates that are required by state statute.
Great. Thank you for all the questions from the committee. Thank you for the testimony. And I think we left out pet insurance in the mandate bill. So
thank you very much.
Wyatt Bosworth, followed by Jennifer Cox.
Chairman Wood, Chairman Cabrera, Ranking Members Wong and Pavlak D'Amato. My name is Wyatt Bosworth and I'm Assistant Counsel with the Connecticut Business and Industry Association. Thank you for the opportunity to offer testimony on 2 bills today, and it's great to see you all in person. CBIA opposes Senate Bill 976, an act concerning health coverage mandates for certain mandates. This really boils down to the testimony you just heard. Every new mandate that's passed gets passed through from the insurance carrier in the fully insured market to the small employer. So we're not necessarily saying consumers shouldn't have bariatric treatments covered. We're saying for the committee to do their due diligence, utilize the health benefit review program, find out the cost benefit of this and see if the mandate's worthwhile to implement. In my opinion, it'd be similar to voting on a tax bill or the budget without having an OFA analysis done. So the process is there and we're just urging the committee to utilize it. We also urge the committee to support Senate Bill 437. This is an act requiring an annual audit and report concerning certain healthcare plans administered by the state. Seemingly, this bill would provide a more in-depth actuarial-based annual audit of the state partnership plan. While the goal to provide municipalities with affordable, comprehensive health coverage is a laudable goal, the partnership plan's financial performance in the past few years has led to double-digit rate increases, multiple years with medical loss ratios over 100%, and recently a number of towns leaving the plan altogether to obtain better pricing and benefits in the private market. Simply put, more transparency is needed to ensure that the plan receives the same degree of oversight that private plans are subject to today. And just a little background, I provided more information in my testimony. Feel free to look at it, but just briefly, from January 2016 to June 22, the partnership plan is operated at a loss by posting an average medical loss ratio of 100.6%. If this were a private self-funded employer program, the CFO would be fired, new consultants would be brought on, and the plan would change. That is too high of an average medical loss ratio for a plan, especially a self-funded plan. And we've seen, a medical loss ratio in excess of 108% in the last plan year. COVID was certainly a boon for the partnership plan, as was any other plan in the state. Medical utilization dropped, and as a result, the partnership plan saved a lot of money. But what we're seeing now is a rebound in utilization, and as a result, a higher MLR. The plan is also going through what we call in the private sector a death spiral. Healthy towns are leaving. Many of you have towns you represent that have talked to you about the plan. They're leaving the partnership plan and going to the private market, blocking with other municipalities on a regional basis, getting experience rated on a health basis, and getting a better rate and better benefits, and they're leaving the bad risk behind. And this is a problem, and certainly needs to be addressed. I think, we certainly applaud Comptroller Scanlon for bringing much needed transparency to this discussion, and accountability since taking office. His recent report that he referenced, acknowledged to plan participants and all of you that the plan is not doing well. And there are a series of proposed fixes that need to be deliberated and looked at.
Wyatt, your time is up. Please summarize.
Happy to take any questions.
Thank you, Wyatt, for your testimony. We on this committee are always looking for ways to be helpful to the business community, especially small businesses. We're hearing constantly about the need for additional products, more competition, and lower pricing. What can we be doing to assist CBIA members? I think we have some of the bills here today that you heard about. Is there anything in addition that you'd like to comment on?
Yeah, I think as Susan alluded to earlier, small businesses they're leaving the fully insured market, in part due to the mandates that are passed, in part due to the inflexibility of the ACA's requirements for rating and plan design. Small businesses I represent, as low as 10 members, are moving to self-funded products today. They're moving to level funded products. They're self-funding, they're purchasing a stop loss policy, and they're designing a plan that better meets the needs of their employees. So I know the committee has raised some concepts this year. One concept we're really looking closely at is to essentially give small employers the same voice and collective purchasing that large employers enjoy today. The ability to aggregate together, to self-fund, to implement value-based insurance design and have that rating flexibility, essentially do what the partnership plan does, right? The partnership plan is essentially an association health plan. The state is the sponsoring association. The municipalities are the members of the association, and they have the ability to group together, combine their experience, implement things like HEP and centers of excellence and narrow networks, and give great value to the municipalities and state employees they serve. So I think we need to look at giving really small employers the same type of plan access that large employers are benefiting from today. It's something that but a number of states are starting to seriously look at and pass. And it's a realization that unless direct subsidies or some type of financial assistance is put into the small group market, which we have never lobbied for and none of you have seriously looked at. And if we don't get a handle on cost control and looking at hospital consolidation and drug pricing and administrative burdens at insurance companies, the small group market, I think, is deteriorating, and we need to come up with something that small employers can pivot to.
Thank you. Any questions from the committee? Representative Barry?
Thank you, Madam Chair. Hi, Wyatt. Nice to see you.
Nice to see you.
Thank you for all that you do for the business community. Have you had a chance to review the annual report by the comptroller that he referred to in his testimony?
I have, yes. I've looked at it every year, every January it's come out.
And are there any deficiencies in that report that could be resolved within audit?
Yeah, I heard the comptroller, who I have tremendous respect for. He's certainly gone above and beyond his predecessor in providing you all information that I think is helpful in your decision-making process. But I think what we're really talking about with an audit is going above and beyond what the auditors of public accounts do today. They're concerned with whether deductions from employees' payrolls are being deducted properly, whether dependents are eligible for health benefits. I think what the committee here is looking for, and correct me if I'm wrong, is an actuarial analysis, right? Something that would go above and beyond what Siegel does, or check what Siegel does. Looking at, has the plan set premiums accordingly the last few years? Have the trend lines the partnership plan has utilized, have they been comparable to the private market trend lines for utilization? What's the effect on the state employee plan? I've heard a lot today about a lot of focus on accounts and is there money moving from one account to the other? I look at it kind of differently. The selling point of the partnership plan is that they pool experience with the state employees. The economies of scale, right? That's why large employers self-fund. The more people you have in a plan, the more you can spread that risk across. So then the question would be, and I think the cost to the state can be better articulated by saying, if the partnership plan is pooling experience with the state plan, and the partnership plan's risk is deteriorating, what effect does that have on state employee premiums, right? Because if the partnership plan is getting unhealthier, which it is, healthier groups are, as I said, leaving the partnership plan, they're going to the private market, they're blocking with other healthier towns and getting better rates, better plan design. If this group is left with a sicker group, that's going to affect the pooled experience of the state employees as well. And that's what we mean by our taxpayer dollars being expended, right? Is the partnership plan dragging the state employee down with it? And what would the state employee plan look like if the partnership plan wasn't pool experience rated? Those are all questions, I think would be prudent to figure out.
Thank you. I think that's exactly what we're looking for, is something above and beyond just a regular audit, and looking at the actuarial valuations as well. Thank you for your testimony.
Yeah.
Senator Wong.
Thank you, Madam Chairwoman, again. Welcome, Wyatt. I think as you represent many of the small businesses, not just our big corporations, but small, mid-sized businesses, the biggest call from the need is health insurance cost. And I think what we're asking here is, you simply want the best plan. You're not prejudging the private marketplaces versus any public marketplace. You want a functioning health insurance program that you actually pay what you've been promised. And I think that's where I've heard over and over again is the struggle within CBIA of that some products aren't as delivered or advertised. Can you just kind of elaborate that for your organization, it's about transparency. It's about accountability and a product that is sustainable and cost affordable with a lot of the cost drivers that this committee is under a review. But ultimately, your role is not to judge one plan versus another. And I think it's clear for people to understand that. But nevertheless, the best viable product, the lowest cost that you can deliver to your members. Would that be fair to say?
Yeah, absolutely. And this is more than health insurance, right? I mean, we have an historic workforce shortage right now, 100,000 open positions. Employers are begging people to come work from them. I mean, there's a 401k match at Chipotle right now. There's pay increases across, the service industry and companies that have traditionally paid lower wages. I mean, wages are going up, benefits are improving, and health insurance is something that is very high on prospective employees' wish list when they want to join a firm. And for small employers to compete with larger employers, it's so important to be able to offer a comprehensive health benefit package. And unfortunately, a lot of them just can't afford the product in the fully insured small group market. I wish that wasn't the case, but the fact of the matter is, Senator, as every year goes by, less and less employers are buying insurance from that venue. They're moving to self-funded products. They're moving to level funded products, which work for many, but all it takes is one employer in a level funded product to have one bad experience here, and they get quoted through the roof, and then they go back to the fully insured market. Many employers now are, instead of taking the risk of signing up with an insurance plan, they're setting up an HRA, an ICRA or QSERA, as we call it, where an employee can just get to, let's say, $200 a month from the employer, and they can bring that money to the individual market, or they can bring it off exchange and they can buy whatever coverage they want. So insurance is changing for small businesses, and I hope to work with all of you to kind of have Connecticut be the model for the rest of the country on how we can really provide affordable, comprehensive coverage to small businesses, but maintain the spirit of what makes Connecticut great with good benefits, insurance companies that are here with good paying jobs and employing people. And we can really be a model for the rest of the country, but something has to change.
Thank you, Madam Chair. Thank you, Wyatt.
Any other questions? Wyatt, thank you so much for your testimony and spending time with us today. Next up, we have Jennifer Cox, who is remote or correct? Followed
Yes.
by Jordan Fairchild.
Hello, can you hear me?
Yep, we can hear you.
Hi, honorable members of the Insurance and Real Estate Commission. Thank you for the opportunity to say a few words. Myself, and I'm speaking on behalf of the New England Center for Hearing Rehabilitation in Hampton, Connecticut, in support of Bill SB 967, specifically Section 15 and 16 that deal with cochlear implantation. We submitted written testimony, so I'll be brief and just have 3 points. Cochlear implants, they are the medical treatment for children and adults with sensory neural hearing loss. They've been proven to be safe and effective. From the first FDA approval in 1984, candidacy has expanded because they've been deemed safe and effective. Insurance, especially insurance that deals with a procedure, a surgery, and durable medical equipment, the cochlear implant is complicated. Mandating coverage for cochlear implants for those with bilateral and unilateral hearing loss will reduce the complexity and time it takes to obtain prior authorization, which for the pediatric population is crucial. I actually think that language should be added to the bill to include coverage of mapping, which is the tuning of the electrodes of the cochlear implant, and oral rehabilitation therapy, which is the specialized listening, speech, and language therapy required after cochlear implantation for success of use of that cochlear implant. And lastly, just on a kind of personal level, although I'm a professional, I work with families on a very personal way, oftentimes in their homes and at the clinic. And they would all say that cochlear implants are a miracle. They are able to raise children in their community that are speaking and talking and are able to go to school with their peers. So to, not have them covered just really actually isn't very logical when you look at the kind of the history of cochlear implantation and how individuals are faring with them. That's it. I just thank you for your time.
Thank you, Ms. Cox. We appreciate your time. Any questions for Ms. Cox? Seeing none, thank you very much for testifying today.
Thank you.
Up next, we have Jordan Fairchild, who's on Zoom.
Yes. Hello. Good afternoon, Senator Cabrera, Representative Wood, Senator Wong, Representative Pablock D'Amato, and members of the Insurance Committee. My name is Jordan Fairchild. I live in Hartford, and I am the coordinator and community organizer for Keep the Promise Coalition, which is a grassroots group of Connecticut advocates with lived experience of mental health conditions, addiction, and co-occurring disabilities. I'm here today to testify in support of SB 976, an act concerning health coverage mandates for certain health conditions. I will mainly be speaking about sections 21 and 22, which would require insurance plans to cover outpatient peer support services. Peer support is recognized by the Centers for Medicare and Medicaid Services as an evidence-based model of care for mental health conditions and substance use disorders. Peer support is delivered by peer support specialists, who are people who have been successful in their own recovery and used their lived experience to help others on their path to recovery. It's been an impactful and critical factor in many of our members' own journeys toward recovery. Right now, Connecticut insurance plans are not required to cover peer support services. The Connecticut legislature has previously been supportive of the continued integration of peer support into our mental health system, including by providing funding last year to introduce mental health peer support specialists into emergency departments. This bill will allow for the hiring of more peer support positions and benefit Connecticut's mental health by joining the many states which already cover peer support. This bill would also require the Commissioner of Public Health to establish a certification and education requirements for peer support specialists. Right now, the Department of Mental Health and Addiction Services endorses 3 organizations: Advocacy Unlimited, Hartford Healthcare, and Connecticut Community for Addiction Recovery, to train and certify peer support specialists. Certifying them through the Department of Public Health would unify the multiple certifications underneath one singular, independent, and legally defensible credential. So in summary, passing this bill would improve the mental health outcomes in Connecticut by expanding and allowing more peer support and allowing the profession to grow and deliver the valuable services that they provide to more and more Connecticut residents. Thank you for the opportunity to give testimony.
Thank you. Thank you, Mr. Fairchild. Are there any questions or comments? Seeing none, thank you very much for testifying today.
Thank you.
Up next, we have Kathy Flaherty. Ms. Flaherty? Welcome.
Thank you so much, Senator Cabrera, Senator Huang, other members of the Insurance and Real Estate Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project. We're a statewide nonprofit that represents people who are eligible for mental health services from DEMIS. So the vast majority of our clients are actually covered by Medicaid. And as far as I can tell, only one section of SB 976 is specifically about Medicaid. But I am here to testify as an employee with employer-sponsored health insurance and as a member of the disability community. Many of the needs faced by people with various disabilities might be more effectively addressed if this bill were to pass. The bill would do what its title says. It would create a number of mandates requiring insurance coverage of certain conditions or of remedies to address those conditions. I joined Jordan Fairchild and others testifying in support of sections 21 and 22, which would provide coverage for delivery of peer support services by certified peer support specialists. Peer support was absolutely integral to my recovery from my mental health condition. Insurance reimbursement would certainly help ensure those services are available to more people. What a lot of people don't know or may not be familiar with is that many psychiatric drugs, especially the older, less expensive drugs, cause serious weight gain as an adverse side effect of the medication. So requiring insurance to cover procedures or medications to treat severe obesity will probably help a lot of people who've taken a lot of psychiatric drugs and have gained a lot of weight because of that. I have many friends and know people with disabilities who rely on service animals. I'm honestly not sure whether the language of section 31 and 32 of the bill is necessarily the most helpful, because it would cover the cost of purchasing a trained service animal from nonprofits that train them. There's no requirement in the law that a service animal, to qualify as a service animal, be purchased from such a nonprofit. The person can train their animal themselves to do the tasks that help them with their disability. So there may be other costs that actually would be more helpful to folks who have service animals. Same for people with mobility disabilities who rely on motorized wheelchairs. There are a lot of issues in terms of availability in the first place, getting them repaired, getting the batteries, but I don't know if insurance coverage alone will solve it. And I just want to add that my focus on these specific sections does not mean I don't support other sections of the bill. These are just the ones that are most relevant to the people I serve. Thank you.
Thank you very much. Any questions or comments? Seeing none, thank you very much for testifying.
Thank
today.
you.
Appreciate it. Up next remotely, we have Mr. Thomas Burr. Oh, in person. Awesome. Welcome, sir.
Yes, thank you. Good afternoon, Senator Cabrera and Representative Wood, members of the committee. My name is Thomas Burr, and I am the Public Policy and Affiliate Relations Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today in support of SB 976, an act concerning health coverage mandates for certain health conditions. For those of you on the committee who may not know us, NAMI is dedicated to building better lives for those with lived experience with mental health conditions and their families. NAMI Connecticut and its 9 local affiliates provide support groups and educational programs for people with mental health conditions as well as their loved ones. And we advocate for policies to improve the lives of people affected by mental health conditions. SB 976 stated purpose is to require certain health insurance coverage for individual and group health insurance policies in this state. As the United States' largest grassroots mental health organization, we know that getting insurance coverage for services in support of people with mental health conditions can often be frustrating and an unproductive experience, which can then lead to poor outcomes. We feel that the following sections of SB 976 can help to change that. 3 different sections, basically. Sections 21 and 22 mandate to have insurance coverage provide reimbursement for peer support services, which we feel would not only encourage more peers to be hired here in Connecticut, which is a good thing because there's a lot of trained ones that aren't currently employed as peer specialists, but also provide for a critical element in aid to recovery for people with mental health conditions, as Kathy Flaherty just mentioned. We know that people respond better when a trained peer is involved in their treatment team, as they have a trusted, empathetic, and knowledgeable connection, often when other people have pulled away from them. Sections 31 and 32 provide for coverage for the purchase of service animals, which can aid in recovery, especially if the animal is a dog, which would need to be walked, and would encourage people to get outside, get fresh air, sunshine, and move. And all of that has been proven to be very beneficial for people with underlying mental health conditions. Sections 45 and 46 provide for coverage for biomarker testing, which may ultimately make diagnosing certain mental health conditions more easier to do and more accurate, which could also accelerate time to recovery. And of course, we know that better diagnoses can save both the patient and the healthcare industry time and money by eliminating trial and error, as well as lead to better outcomes, as people who don't get the proper treatment can often become disenchanted with the medical model of treatment and disengage from it. So therefore, our organization supports those 3 sections of SB 976. And again, that doesn't mean we don't support other stuff, but I want to just focus on those for the benefit of our membership. And I should note that the leadership of this committee may have already heard from over 100 of our members on this bill and are also very supportive of it. So thank you for your time and attention. I'll gladly answer any questions you might have.
Thank you very much. Any questions, comments? Yes, Representative Wood.
I just want to thank you and your team for reaching out and educating us on all the things that are important to your group. I think you do a really good job of organizing. One thing I will say, I have been emailing back and forth with a lot of these form emails that we're getting, and they don't have insurance coverage that our committee regulates. So I just want to make sure that you can help, educate your members on the market that we do regulate, which is very small. It's a fully insured market.
No.
A lot of people on the Affordable Care Act plans.
Understood.
All right. Thank you.
Thank you.
Thank you, Senator Wong.
Thank you, Mr. Chair. I want to echo the Madam Chairwoman's accolades to NAMI and the work that you do, your outreach initiatives, your member outreach are invaluable. So I want to commend you, Tom, for your work. I can count on an email every week from you. And I think it's important. You're representing a constituency that sometimes doesn't always get heard. And I think you work extremely well as an organization, and you particularly, I want to compliment you in helping break out the stigma of mental health, and been to enough of your peer group meetings to really the work that you do to affirm parents and family members that struggle through with the challenge of mental health. I think I've heard it enough times to reinforce the value that you bring is many of these parents leave the meeting with hope and understanding that they are not alone. So I want to thank you. I want to acknowledge you and thank you for your great effort. Thank you, Mr. Chair.
I appreciate the kind words, Senator.
Thank you, Senator. Okay, I see no other questions or comments. Thank you very much for your time
Thank you.
today. Up next, we have Miss Lisa Williams.
Hi, my name is Lisa Williams. I am from Wilton, Connecticut. I'm here in support of SB 976. I'm a parent of a young adult with PANDAS. This is my third time coming to Hartford. This insurance mandate has been presented before, so I will keep coming. Right now, 10 states have insurance coverage for PANDAS. There are hospitals and universities across the country that have clinics or departments devoted to helping PANDAS. Still, there are not enough providers and people educated. And one thing with insurance coverage, it'll put PANDAS on the map, and practitioners and parents and everybody involved in childhood education will know what it is. So that's a secondary benefit to the financial gain or relief that parents would have. My son started showing symptoms of PANDAS at age 2.5. The pediatrician sent him to birth to 3. He was misdiagnosed. He was misdiagnosed with everything from apraxia to PDD, NOS to autism. And then when he continued to miss his milestones, he was put in special ed preschool. He did a 3s and a 4s program in Wilton. Again, all the evaluations misdiagnosed him. That was a lot of time and money spent by the state and the school district. That was a complete waste and could have been saved or used for other children. By happenstance, he was hospitalized with asthma when he was 4.5. And while he was hospitalized, they gave him strong antibiotics and steroids. And all of a sudden his symptoms melted away. Therefore he started talking, he was potty trained, his temper tantrum stopped, his rage went away, and he was mainstream for kindergarten and without an aid. It was like literally a miracle. And the special ed preschool said he was just developmentally maturing and all the therapy he was getting in special ed was helping. But now looking back, we know that's not true. Fast forward a few years, he started exhibiting paranoia, food restrictions. He was afraid food was contaminated. He was paranoid. He had irrational fears, OCD, and anxiety. We went back to a pediatrician, and we were down the psychiatric route. He didn't have any improvement. He was considered mild because he was able to function in school and get through the day. At home, he would fall apart, and he had some supports at school to help with his anxiety and his OCD.
Lisa, your 3 minutes have eclipsed. Please summarize.
Oh, okay. I guess what I want to say is that early treatment is key, and not only will this mandate reduce the financial burden on parents, but it will save money in special ed and in birth to 3 with these kids who are misdiagnosed. And most importantly, some kids with PANS and PANDAS end up committing suicide. Their brain is so inflamed, they can't even think straight, and they don't know what they're doing. So we all know suicide rates are on the rise. And I know parents personally who have lost children to this. So the mandate will save lives if people could get proper treatment early and quickly and intensely. Thank you.
Thank you, Ms. Williams. Thank you so much for your advocacy and your willingness to share your story yet again. And our hearts go out to you. And thank you for your advocacy.
Okay, thank you.
Oh, I'm sorry. Wait,
I have-
we're back.
Oh,
Sorry.
Thank you.
I didn't see him.
I want to let everybody on the committee know that this is my first constituent who has come and presented for me at a committee.
Oh,
So thank you very much.
oh, you're
I'd
welcome.
appreciate you coming up here. I appreciate you coming back. And it turns out that I think we are neighbors. We live behind each
Yeah.
other. We just haven't met yet.
Yeah.
And so in Wilton, that's easy to do. But thank you for your testimony. Can you just tell us really quick the cost it's been to your family?
The financial cost or the
And the
emotional cost?
emotional, just very quickly.
The financial cost when he was in birth to 3, we supplemented for speech therapy because he wasn't talking, and my husband's insurance would only cover a certain amount of speech therapy. And the same when he was in special ed preschool. So that was we supplemented ourselves. All the psychological, when he had his second quote unquote flare, we went down the psychiatric route and we did therapy every week with a psychologist to try to, and it helped minimal. But that was a cost. And at the time I was going through breast cancer and my son was off the rails. So I'd go from chemo treatment, drag him to the therapist. My husband was working, he couldn't take off. It was just a bad situation. And it was so ironic. My cancer was covered perfectly, but my son, you know, all the therapies, it was, the psychologist just wasn't covered by insurance, and we were going once a week to try to keep him from going off the rails. And then our PANDAS specialist is not covered by insurance. Her visit, the lab work, the blood work, the antibiotics and the steroids are covered by our insurance, but the actual meeting with her, and we have to see her at least once a year, sometimes more if he has a flare.
Thank you. And I appreciate you sharing your story. And come over and see me sometime at home.
Oh, I will.
Okay.
I walk by your house.
All right, thanks.
I think he wants your vote. That's what I think. Senator Marks, I'm sorry, ma'am. One more. Sorry.
Sorry.
I apologize.
It's okay.
Hi, thank you for your statement. So you didn't really get to finish. Can you tell us how your son eventually did get diagnosed? How old was he? And where is the PANDAS specialist?
It turns out he was 12 and he started getting worse and worse, even though he was seeing the psychologist, and he started with physical tics. That was the last symptom he got. And there was a mom in our town whose daughter had physical tics. She was an acquaintance. And I said, what is it that your daughter has? Have you gone to a doctor? And she goes, oh, my daughter has PANDAS. And I was like, so then I started talking to her about my son. She goes, Lisa, that's a lot of the symptoms. So she put me in touch with her specialist who was in Darien. And now we see, he was an immunologist, and then he could only get my son so far. And then we started seeing an integrative pediatrician who treated him, and she's still with the practice. But it was another mom. And, I don't think anybody purposely made mistakes. They just didn't know because the word wasn't out there. But when things are covered by insurance, it gives it credibility. And the doctors, I think, will pay attention to it more.
So did he ever get the IVIG, or was he just treated with steroids and antibiotics?
Yeah, by the grace of God, he didn't need IVIG. With steroids and antibiotics, he was fine. And then some supplementation for a genetic part that his body can't detox so well. He's on a supplement for that, and they boosted his immune system, because every time he gets sick, if he had a bike accident, he got all scraped up and he had a flare. Anything that the body causes immune response, whether it's a cold, the flu, you can have a flare. So he's on maintenance stuff. And then if he has a flare, his specialist adds some things to it, but that's all medication. He hasn't had to do IVIG. And that's another important point about this bill, is not every kid needs IVIG. And if you could get them early, or if you have a more mild case, I mean, mine is considered mild. It was still heartbreaking and a huge road. Other parents are in much tougher spots than I was with my son.
How's he doing now?
He's good. He's in college.
Yay,
Which you would
congratulations to
never,
you.
ever think. And he still has flares, but he knows when he's starting to go down that road. And then we get in with the specialist and she kind of tightens things up a little bit. The only thing that never recovered was his handwriting, but he's not going to be a doctor, so that's okay.
No, he'd be a fine doctor. If his
yeah,
handwriting's bad. Yeah.
But you know, one of the sad parts is he remembers those years. He doesn't remember when he was 2.5, but he remembers the anxiety and the OCD and the depression. And we both know those were wasted years, you know, and I think that's what makes him sad. So,
Yeah. Well, good job. Good
thank
job.
you.
Yeah.
Thank you. Thank you so much. Up next, we have Anna Doragazi. Am I saying that right? Welcome.
Thank you. And good afternoon, Senator Cabrera and Representative Wood, ranking members of the committee. My name is Anna Doragazi, and I'm one of the policy directors at AARP Connecticut. I'm here today to ask for your support of House Bill 6619, an act concerning banning pay for delay. While most of us have been feeling the squeeze of inflation when we buy gas, groceries, and other commonly used goods, the price of these price increases pale in comparison to the year over year increases in the cost of prescription drugs. According to recently released report from the Federal Department of Health and Human Services, there were 1,216 prescription drug products whose price increases between July 2021 and July 2022 exceeded the inflation rate of 8.5% for that time period. For those 1,216 drugs, the average price increase was 31.6%. These ever escalating prices disproportionately harm older adults, as they typically take more prescription drugs than younger adults, and they live on fixed or lower incomes. Our written testimony highlights a few stories from AARP members who have shared with us how high drug prices have impacted their lives. One of these AARP members shared the story of a 50-year-old family member who stopped taking a medication she could no longer afford and was found dead in her apartment. As this member put it, in this case, greed caused death. There's no single magical policy fix that's going to fix the high price of prescription drugs, but HB 6619 would address one particularly egregious practice called pay for delay that, depending on the source you consult, costs consumers between $3.5 billion and $6.2 billion in higher prescription drug costs each year. A pay for delay agreement is an arrangement between a brand name drug manufacturer and a competing generic manufacturer, where the brand name manufacturer gives something of value, whether it's money or a promise of limited legal action, to the generic manufacturer if they agree to delay the release of their generic drug equivalent. Brand name manufacturers get to maintain exclusivity in the market for a longer period of time. Generic manufacturers get some kind of financial benefit to not sell their product, and consumers pay the price. HB 6619 would create a presumption that these patent settlement agreements are anti-competitive and illegal. We believe that this legislation will provide consumers with faster access to generic drugs. And because these generics can be up to 90% cheaper than their brand name competitors, helping these products come to market faster will play an important role in lowering prices and making sure that Connecticut residents have access to the medication they need to stay alive and well. As noted in our written testimony, while we support the bill as written, we do think it could be improved by the addition of a severability clause. I appreciate the opportunity to testify today, and I'm happy to answer any questions. We hope you'll join us in supporting HB 6619.
Yeah, that was.
I
good.
practiced, yeah.
Very good. Thank you. Any questions, Senator Marks?
Thank you for that testimony. I'm a visiting nurse, and most of my patients makes me feel young. They're still older than me. So, and just one of the examples is Eliquis, which you take for a blood thinner, and you don't have to take, it used to just be Coumadin, but you have to go for the weekly blood work, or every other week, and there's a diet restriction on Coumadin, and Eliquis prevents a stroke and is wonderful, and it's costing people $700 a month, so they can't take it. And I believe there is a generic out there yet, but like you said, it's just not a Pixabam, I think. So bravo. Yeah, it really is awful. And we have to be kinder to those that have taken care of us for decades. Thank you.
You're welcome. And Eliquis is one of the ones that I've learned by name because we hear about it so much from members that it's one of those life or death medications. And yeah.
Representative Wood.
Thank you. Thank you for coming and testifying. Can you just explain the severability clause and how that would be better suited into this bill?
Sure. So that would just indicate that if any piece of the legislation is somehow struck down in court, that other pieces of the legislation would still apply. And we put some model language for that based on legislation from another state into our written testimony, just as an example.
Senator Wong.
Thank you, Mr. Chair. It's good to see you and welcome. I think you picked a great day for all of your great members who are such activists on St. Valentine's Day dressed in red. So, but I do want to compliment yourself and Nora Duncan and the advocacy that you have for our active seniors in regards to that. And ultimately, I appreciate the Madam Chairwoman's ask about the severability because that was helpful. But nevertheless, I just want to acknowledge and thank you and your memberships for their activism and engagement in the democratic process. Thank you.
Thank you.
Thank you, Senator. Any other questions or comments? Nope, seeing none. Thank you very much.
Great. Thank you.
Have a great day.
You too.
Up next, we have Monica Villager.
Hello. Yes, Bilger. Thank you very much. Chairwoman Wood and Chairman Cabrera and honorable members of the Insurance and Real Estate Committee, thank you so much for the opportunity to speak before you today in support of Senate Bill 976. Specifically, the American Diabetes Association supports improving access to care by broadening health insurance coverage for people living with obesity, including FDA-approved anti-obesity medications. As I mentioned, Monica Bilger, and I'm the Director of State Government Affairs for ADA. I'm here on behalf of the over 1 million people in Connecticut with or at risk for diabetes. As you all very well aware, diabetes is an epidemic in the United States, and according to the CDC, over 34 million Americans have diabetes and face devastating consequences. And what's true nationwide is, of course, also true in Connecticut, with over 9% of the state's adult population having diagnosed diabetes and more than 33% having prediabetes. Correspondingly, we are gravely concerned about the substantial increases in obesity and the related impact on diabetes. Obesity accounts for up to 53% of new cases of diabetes each year in the United States. And in Connecticut, the percentage of adults with obesity has been trending up as well. Now we're almost in 2019, it was at 29%, down, up from 24% in 2013. And the trend continues in the youth as well. And they're at 29% of Connecticut children, 5 to 17, are overweight or obese. What's more staggering is these numbers aren't even reflecting the added impact of the pandemic on the rising obesity crisis. The proportion of kids who are overweight or obese has been climbing steadily for years and surged during the pandemic. Last year, an article in the Hartford Courant outlined the local impact of this crisis, and it highlighted the waitlist at the Pediatric Obesity Center for Treatment, Research, and Education at Connecticut's Children's Medical Center, where pediatrician referrals have nearly tripled. They were like 890 in 2019 and almost 3,000 in 2021. We can't also speak to diabetes and obesity crisis without highlighting the glaring facts related to health disparities. With our recent health equity bill, we want to envision a future without unjust disparities. And for example, in Connecticut, non-Hispanic, Black, or African-American, Hispanic, Latino Connecticut residents are more than twice as likely as white residents to be diagnosed with diabetes. Similarly, Black and Hispanic adults also have the highest prevalence of obesity in the state. There's strong and consistent evidence that obesity management can delay the progression from prediabetes. Our 2023 standards of care recognize that obesity is a chronic and progressive disease, and with numerous medical, physical, and psychosocial complications. ADA recommends a comprehensive access to and coverage of person-centered obesity treatments and services to urgently address this obesity epidemic. And as detailed in our standards of care, this includes intensive behavioral nutritional counseling, physical activity, and obviously access to the FDA-approved meds and short and long-term weight management, as well as metabolic surgery when needed. On behalf of people living with and at risk for diabetes in Connecticut, we thank you and urge your support for SB 976.
Thank you, Monica. Any questions? Monica, thanks for presenting your testimony today. We appreciate it.
Thank you so much.
We have Ashley Van Meter, followed by Allison Malerba.
Hi there, my name is Ashley Van Meter. I am with the Association for Accessible Medicines. We represent the nation's leading generic and biosimilar manufacturers. I'm here today to testify in opposition to the patent settlements ban bill 6619. One thing I'd like to say about prior testimony is it unfortunately neglects to discuss a really important point in time that changed the landscape. That was the FTC versus activist decision that was handed down in 2013 and set up a successful federal framework that addressed most of the issues that they're discussing. I heard a lot of quotes about the FTC. It is important to discuss the FTC because they do review every one of these settlements. In fact, on their website, they discuss the types of settlements that are of concern are down at an all-time 15-year low. Also, I heard a lot of discussion about savings as a result of banning settlements. Unfortunately, it is the exact opposite. Settlements to date have saved upwards of $11 billion to consumers. I would point to a group of settlements that happened this year, a settlement that was put in place for seven different biosimilars to the blockbuster drug Humira, for example. Humira created a patent thicket around the drug, or AbbVie did, around Humira. There were over 100 patents that had to be challenged. In patent litigation, you don't just challenge one. You have to win on all of the patents around the drug. With the patent settlement that was put in place with Humira, one biosimilar was just launched a few weeks ago, an interchangeable and a biosimilar. And by July, we'll have 6 more competitors to the biggest selling drug of all time, besides the COVID vaccine. I should say that that was upwards of a decade earlier than would have been the case. So we have 7 competitors to the most successful drug of all time happening this year because of a patent settlement. Also, there was discussion about drugs being the largest cost of healthcare. I just want to point out that generics are 2% of overall healthcare costs, even though we're 90% of scripts sold. This bill, unfortunately, is modeled after a bill in California that right now it is enjoined from being used against members of AAM because of constitutional concerns. I highlighted some of those in my testimony that I have submitted, and I'd be happy to go through some of those. But I would just highlight that settlements, the way that they were pre-activists, do not exist today. The Supreme Court has set up a successful framework, and because of settlements, generics and biosimilars are coming to market sooner. And in fact, generics, again, like I said, this is the 10th year in a row, according to AARP's study, that we are now 9.3% down this year alone in costs. So with the tool of patent settlements, you're actually encouraging generics and biosimilars to come to market sooner, not later. Some of the terms, like you hear pay for delay, those do not happen post-activist. A lot of the criteria that you're hearing—
Your 3 minutes have eclipsed. Please summarize.
Okay, I would just say that there are constitutional concerns with the bill. I'd be happy to refer you to my written testimony, and I'd be happy to answer any questions.
Thank you, Ashley. I do have a few questions. You had said that generics are coming to the market sooner than ever. Do you have any data to support that?
Sure. I mean, I did reference with the Humira example.
Yeah.
So that patent would have extended through the 2030s. Had the drug companies that launched at risk against that with that drug would not have, if they would not have done that and then gone to settlement, if they would have had to go the whole way, possibly to lose, generics lose 70% of the time. And if you go the whole way to the end of patent litigation. So with Humira, there would have been another 10 years to 11 years on that patent for that drug. With these settlements, one launched, I think about 2 weeks ago from Amgen, and in July, there will be 6 more. And if you look at the cost, for example, of Humira is around $20 billion a year. And so with now 7 different competitors, we expect to see the drug costs going down. With something interesting that we've seen is when biosimilars come to market, we see after they've been on the market, on average of saving 50% from the reference product. And also something that we didn't expect to see is we've also seen a 25% reduction in the reference product, the brand products cost. So the biosimilars are driving the cost down for consumers. That's now going to happen a decade sooner because of those patent settlements.
I mean, your testimony is really intriguing to me, and I do want to dive into it a little bit further. I haven't read your online testimony, but if you have additional data points on some of these questions, please feel free to send them over. The patent settlement process, can you just explain that a little bit more to the committee? So basically, my understanding is that there's a drug that comes out, and then a generic puts out a similar, and then are you sued?
Yeah, it's sort of like a patent dance that starts to happen as soon as we launch. Then you have a situation where the brand company will sue. Then there's a stay that's put in place for the litigation to move forward. It's supposed to happen, finish within that time frame. Like I said, unfortunately, in patent litigation under Hatch-Waxman and the types of litigation that we're talking about, you have to litigate on every single one of the patents, and you have to win. Even if you win 99 of the 100 patents on Humira, you're not going to win that litigation. And so having the ability to settle is crucial. Without it, generic drugs will not launch at risk. If they know they have to fight 100 different patents and win on every single one, when our success rate is around like 30% right now, they're not going to do it. You're not going to have competition. And so when these settlements happen, the FTC versus activist decision stopped what everybody's calling paying for delay. They set up a framework of what would be an anti-competitive settlement. And so one of the things that we've recommended is, because activists has worked so well, we've recommended codify. If you're worried about it, codify activists. Make it so that the decision that the Supreme Court handed down that the FTC has acknowledged is working, put that into statute. Because otherwise, if you do some of the things that we see in this statute, this is modeled after the California bill, we see a lot of constitutional issues with it.
Okay, so I think we could probably talk a little bit more offline, because our goal is to benefit the consumer. And what I'm hearing from you is that this pay for delay, as it's currently written, you oppose it completely. It would not be beneficial to the consumer, and you would. Okay.
It would not. And we think actually it would benefit brands, because there would be fewer and fewer generics and biosimilars willing to try to launch at risk.
Okay. Yeah. I think it'd be helpful for the committee, while we're exploring this, to price out the brands versus the generics and the biosimilars, because the little research I've done on it, the costs are, the brands and biosimilars is extremely high, and the generics are extremely low. So we'd like to just explore that further. I could ask a lot more questions, but I'll pass over the committee. No, anyone else? Okay, great. We will definitely talk more offline. We appreciate your testimony.
Thank you so much.
Next, we have Allison Malerba, followed by Christopher Gallagher.
Yes, hi. Good afternoon, honorable members of the Insurance and Real Estate Committee. Thank you very much for the opportunity to speak to you today in support of proposed Senate Bill 976, an act concerning health coverage mandates for certain health conditions. Specifically, our support is for sections 15 and 16, which pertain to insurance coverage for cochlear implant devices and surgery. I'm speaking on behalf of the Connecticut chapter of the Alexander Graham Bell Association for the Deaf and Hard of Hearing. We are a diverse group of parents and professionals that support individuals and families of children who are deaf and hard of hearing that have chosen to communicate.
So sorry to interrupt.
Sure.
Your video feed is extremely.
Oh
glitched.
my, can I just turn off my video while I speak to you?
Yes.
Okay, thank you. My apologies. So as I was saying, we are a diverse group of parents and professionals that support individuals and families of children who are deaf and hard of hearing that have chosen to communicate through listening and spoken language. We are dedicated to educating and increasing public awareness about childhood hearing loss and advocating for the importance of early diagnosis and high quality intervention. Approved for the adults by the FDA in 1984 and for children 2 years and older in 1997. This technology has been paramount in helping individuals who are deaf and hard of hearing learn to listen and talk. So much so that the FDA has approved cochlear implants for children as young as 9 months, as well as for individuals with single-sided deafness and asymmetrical sensory neural hearing losses. The body of research that supports cochlear implant efficacy is substantial and continues to grow. We have learned an extraordinary amount about the appropriate intervention for individuals who are deaf or hard of hearing learning to listen and talk. We know that hearing aids are not always able to provide enough access to the speech acoustics necessary for the development of spoken language. We've also learned that one ear is not good enough and poses a greater risk for academic and social emotional delays. And we've learned that taking a wait and see approach is harmful to the development of children who are deaf and hard of hearing. In fact, we now know that delaying appropriate auditory access has been shown to negatively alter the brain's neural connections, which increases the risk of not achieving normal spoken language. Language acquisition is most critical in the first years of life, and delaying appropriate medical and habilitative or rehabilitative intervention is detrimental to a child's development. The fact that we have such an extensive amount of evidence showing the benefits of cochlear implantation makes it that much more concerning that some health insurance plans do not cover the procedure for those determined to be candidates. As parents and professionals, we are so fortunate for the advancements in hearing technology that allow babies and young children who are deaf and hard of hearing the opportunity to listen and talk, to flourish alongside their hearing peers, and to become active contributing members of their community and beyond. Research supports that early and appropriate intervention yields better outcomes. Cochlear implants make this possible and should not be denied due to inequitable health coverage. Thank you for your time and consideration for passing proposed Bill 976. We hope that cochlear implants and surgery are covered regardless of health insurance coverage by a carrier. Thank you.
Thank you, Allison. Any questions? Thanks for your time today, Allison.
Sure, thank you.
Next up, we have Christopher Gallagher, followed by Linda Alderman.
Thank you very much, members of the committee. I am Christopher Gallagher, Federal and State Affairs Consultant for the Obesity Action Coalition. And on behalf of the more than 78,000 patient members of the OAC and 1,100 Connecticut-based members, I'm here to express our support for Senate Bill 976, which would require broader health insurance coverage for bariatric and metabolic surgery and FDA-approved anti-obesity medications. Throughout the past decades, the prevalence of obesity has skyrocketed across our country, with now more than 30% of Connecticut citizens affected by obesity. Despite this fact, many policymakers continue to view obesity as a lifestyle choice or personal failing. These perceptions and attitudes have allowed health insurance plans to take vastly different approaches in determining treatment coverage. Since 2013, when the AMA adopted formal policy classifying obesity as a disease, numerous other organizations have stepped up, including the National Council of Insurance Legislators, National Lieutenant Governors Association, and the national organizations representing Black and Hispanic state legislatures have all called for access to obesity treatment. And just recently, the Office of Personnel Management that manages federal employees' health plans has updated their obesity guidance to say that health plans can no longer have exceptions or carve-outs for anti-obesity medications approved by the FDA. This is significant because OPM issued guidance in 2012 that asked plans not to discriminate against AOMs because of the plan's view that it is a lifestyle condition or cosmetic treatment in nature. And they saw that given about 10 years, health plans needed that extra kick, if you will, to actually provide coverage for obesity treatment services. And then finally, I would like to say that we're pleased that the American Academy of Pediatrics has recently released new treatment guidelines on obesity for children and adolescents, recommending intensive behavioral counseling, pharmacotherapy, and bariatric surgery, depending on the age of the child and the BMI included. In summary, I would just say our country needs to start treating obesity as the chronic disease that it is, just in the same fashion we treat diabetes and hypertension. And I really appreciate the support from the American Diabetes Association, as voiced by my colleague a few witnesses ago. And I'd be happy to take questions.
Thank you for your time. Any questions from the committee? Great. Thank you for being with us today.
Thank you.
Next up, we have Linda Alderman, followed by Susan Regan.
Esteemed members of the Insurance and Real Estate Committee, my name is Linda Alderman, and I've lived in West Hartford for over 30 years. I'm a survivor of a rare disease, a two-time survivor of breast cancer, and am honored to be the Connecticut State Lead Volunteer for the American Cancer Society Cancer Action Network. I'm testifying in partial support of proposed Senate Bill 976, an act concerning health coverage mandates for certain health conditions. My support and testimony concern only sections 45 and 46 of the proposed bill, which relate to biomarker testing insurance coverage. I thank you for the opportunity. I was devastated to see the pathology report after my double mastectomy in 2008, because it stated that my malignant tumor was 2.5 centimeters, and I knew that any size over 2 centimeters meant that I would need chemotherapy. The prospect of receiving chemotherapy is terrifying for the reasons we all know, but I had another reason to be afraid of chemo, and that was because I was recovering from a rare disease, Cushing's syndrome, that had caused significant cognitive impairment. I'd been an environmental attorney for 20 years, but Cushing's had caused memory loss and impacted my speech and processing so profoundly that I had become disabled from the practice of law. If I received chemo, my cognitive impairment would most likely be permanent, and I might not have any meaningful recovery. There was also the real possibility that chemotherapy could cause additional damage to my cognitive and processing functions. But then my oncologist told me about a new biomarker test for breast cancer patients called the Oncotype DX that would be performed on my tumor's pathology and would tell us not only if my tumor would react to chemotherapy, but if chemotherapy would prevent recurrence. Instead of immediately being given a one-size-fits-all chemo treatment, I was fortunate enough to receive a biomarker test that analyzed my specific tumor and determined the best course of treatment for it. Thankfully, the biomarker test results informed my oncologists that I had a very low risk of recurrence and that I would not benefit from chemotherapy. We currently have life-changing tests that could lead to better health outcomes, increased quality of life, and reduced costs that patients won't be able to receive because they can't afford it. Simply put, there are patients who could benefit from biomarker testing who don't have access to it because their health insurance won't cover the tests they need. This seems counterintuitive to me because biomarker testing could lead to a significant cost savings for health insurers. For example, in my case, the biomarker test not only saved my health insurer from the significant cost of chemotherapy, but also from all of the future health care I most likely would have needed to not only treat the typical side effects of chemotherapy, but also for the medical and behavioral care, as well as the occupational therapy and lifelong care I would have required if my cognitive function had been permanently and/or further impaired. Sections 45 and 46 of SB 976 will not only open the door to treatment that can save lives, but could provide a significant cost savings to health insurers, like my biomarker test provided a significant cost savings to my health insurer. And I hope that you will look favorably upon these sections of the proposed bill. I'm happy to answer any questions.
Thank you, Linda.
Yeah.
So let's talk about when a biomarker test is available. Do doctors say you would benefit from this, or, here's the cost? How does it work? I mean, it seems like everyone should be getting a biomarker test, right?
I
From your testimony. So
I absolutely agree. They
Yeah.
should be
Right.
getting them. And in my case, the biomarker test was advised, and so it was sent out. I can't really speak to whether they are or aren't proposed if the person is uninsured. I really can't speak to that, but I agree, they should be covered, and every person who it would benefit should receive it.
now, did you have a copay, or did you pay 100% out of pocket?
In my case, it was so early that it was still, it wasn't covered by insurance, but at that time, the laboratory covered it because I was going to add to, their information. So they were just building up their database. And
Oh, okay.
so it was not covered by insurance. It was denied, but I didn't pay for it.
Okay, so
That doesn't occur anymore in most
because
cases.
they built up their database, and so at
Correct.
this point,
Yeah, this was 2008. So it was a
Okay.
really long time ago.
Okay, excellent. I've learned a lot from your testimony.
Okay, thank you.
And any other questions? Representative Denning.
Thank you, Madam Chair. Thank you for giving that testimony. A lot of people are not aware of the new technology and science coming up with not only biomarkers, but DNA technology
Yeah.
that we can learn by examining the tumors and the patient's actual tissues as to what will actually treat them. And how are you doing?
Actually, thank you for asking. A week from now, I will be 10 years without disease. So
Congratulations.
thank you. Yeah, it's an exciting week for me.
Thank you for coming today.
Thank you.
Susan Regan, followed by Fame Muhammad.
Yes, well, thank you, honorable members of the Insurance and Real Estate Committee, for the opportunity to testify regarding your consideration and deliberation for our program to be included in your approval of SB 976 for individual health insurance policy providing coverage of the type specified in line 346 through 349, which is an act requiring health insurance coverage for equine therapy approach to remedy the issues faced by our U.S. veterans suffering from PTSD. I also wish to thank Senator John Kissel for raising proposed Senate Bill 458, which has brought us to today's venue. My name is Susan Patricelli Regan, president of Foxfield Farm, a 501c3 foundation established to treat the anxiety, distress, and often shame associated with post-traumatic stress disorder. I believe that it is important to state the meaning of PTSD as we assume that with a veteran, that their issue was derived from the exposure to terrifying events during their military service, that may also have been triggered to alternative sources or exacerbating stress leading to triggering the PTSD diagnosis. And here is that explanation. Post-traumatic stress disorder is a mental and behavioral disorder that can develop because of exposure to a traumatic event, such as sexual assault, warfare, traffic collisions, child abuse, domestic violence, or other threats in a person's life. Symptoms may include disturbing thoughts, feelings, or dreams related to events, mental or physical distress to trauma-related cues, attempts to avoid trauma-related cues, and alterations in the way a person thinks and feels, and an increase in fight or flight response. I did submit to co-chair Senator Lesser and Mr. Cabrera, as well as the committee members on January 19th, 2023, my comprehensive outline as equine management and instruction as a cogent approach to treating PTSD veteran patients. The following summary excerpts from that two-page document. I believe that this perspective meets several objectives. Providing optimum options for our brave servicemen and women who suffer from PTSD and related mental issues. It is physically oriented and prudent in our budget challenged state by capping the outside cost. a lower cost approach that can supplement or even replace more costly clinical therapy prescriptions methods. Therefore, we're looking at return on investment and expediency of results. Now today, I have heard many of the testimonies are virtually a majority of them are related to prescriptions and medications. Our program is not. It is a health-oriented program. There is lower risk, less stress. It's educationally trade-oriented and functionally more enjoyable for the participants. It reduces the risk of opioid overdose and
Susan,
addiction.
your 3 minutes have eclipsed. Please summarize.
Thank you. Self-medication, which is alcohol-related, which can result in further disorientation and suicide. Thank you for your time. I welcome any questions.
Thank you, Susan. Where's your facility located?
In Granby, Connecticut.
Granby. I think it'd probably be in the best interest of some of us on the committee to visit and see this in action. I think it would be good. So we'll definitely follow up with you on that. And any other questions?
That would be great. Great. I welcome it.
Okay, good. We'll follow up with you. Thank you so much for your
Thank you.
testimony. Next up is Fame, and I would like you to pronounce your last name so I don't mangle it any further.
Yes, my name is Fami Mamuya. You actually pronounce it very correctly.
Oh, thank you. And I'm sorry about that.
Yes, yeah, I'm a resident of Manchester, Connecticut, and I am also a research scientist over at Equine Health Center, or working on oncology. And I'm also a cancer survivor. Right now, I am in remission for over 20 years. What I wanted to do today, first of all, I'd like to thank Linda Alderman for starting the same thing I am going to talk about today, because I'm here to testify in partial support of the proposed Bill 976, but specifically on the section 45 and 46 of the proposed bill, which related in biomarker testing and insurance coverage. Maybe I could start this by just telling a small story when it comes to where we are with the biomarkers right now, and really why are they so important. So if you look at the last 20 years, the last 2 decades, there have been a significant increase in research, especially in cancer. We had a number of publications and a number of the results led to the advance that we have right now in terms of treatment. However, if you look at the amount of research and the survival rates, it's some point is telling you that something is missing, because it's really, I would say, not matching. So there are factors that are causing this, but one of them is that we have been for years treating cancer as one drug fit all. In that case, we all know the says that somebody can go and get treated with cancer, successful, whereas another person getting the same treatment failed the treatment. And this is due to the fact that cancer has a phenomenon called heterogeneity, meaning that the cancer that you might detect during biopsy, it might not be the same cancer or type that respond to the same drug after treatment or during disease progression. And with this being the case, you are allowing it to continue grow while you're using the same drug that was determined during biopsy. Now, with the biomarkers, which now these are the game changer, what they do, some of them have the ability of looking at cells that are coming originally from the tumor that are circulating in your bloodstream at that particular time. So what the clinicians can do is they can go in, get those cells, look at them with the biomarkers and say, you now have this, not what you had prior. And this is the treatment that we're gonna change treatment. So they will allow a clinician to monitor treatment in real time. Now, this is not something that can be a choice because of insurance.
Tommy, I'm just going to interrupt. Your 3 minutes of eclipse, please summarize.
Okay, Yes, yes. So this is not something that can be a choice. I think everybody has a share, has to get a share of this because it is the reason that's going to really make a trend and a change in cancer, and it helps survivors rates increase. Thanks. Any questions for me?
Thank you, Fame. You and Linda really provided a lot of insight on this testimony, and you know, I appreciate your time on it. It's something that we definitely should dive into. I see nothing but benefits to patients that need it and are seeking treatment to identify the best approach. So any questions? Great, thank you. Next up, we have Alexander Nawia, followed by Darren Tischler. Is Alexander here? No, okay. Darren Tischler, are you here? Is he on remote? Okay.
Can you guys see me now?
Yes, we can see and hear you. Please continue.
Okay, thank you. I appreciate the time to speak. Honorable members of the Insurance and Real Estate Committee, I'm Dr. Darren Tischler. I'm a resident of Glastonbury, Connecticut, testifying in support of Senate Bill 976. I am currently the president of the Connecticut chapter of the American Society for Metabolic and Bariatric Surgery, and I'm the chief of metabolic and bariatric surgery at Hartford Healthcare. I'm a bariatric surgeon who's had the privilege of treating thousands of patients with obesity in my career, all here in Connecticut. I treat and often cure health problems like diabetes and high blood pressure, chronic pain, and other serious health conditions related to obesity. Most importantly, I help patients live a longer life and improve their quality of life at the same time. I offer life-saving treatments for obesity. Too often, however, these treatments are not covered by certain insurers, including the Connecticut Affordable Care Act plans. Throughout the past decades, the prevalence of obesity has skyrocketed across our country, with now more than 30% of Connecticut residents affected by obesity. Obesity is a disease that affects all age groups, races, and demographics, but disproportionately affects lower socioeconomic classes and minorities, and often those most in need. Obesity causes more than 200 health conditions, including cancer, diabetes, high blood pressure, and leads to early death. More than 25% of Connecticut residents are affected by obesity, and nearly 10% have type 2 diabetes. The costs of obesity are staggering, and the healthcare costs for those with obesity are 42% higher when compared to those without obesity. We need to treat obesity like cancer: prevention, early detection, treatment, and multimodal treatment before irreversible health conditions and complications develop. In my personal experience, in the experience of our Connecticut ASMBS members, there is significant stigma and discrimination against those with the disease of obesity perpetrated throughout our society, including the workplace, and with the lack of protections available for those suffering from obesity. As a physician, I have a responsibility to act in a fiscally responsible manner, but at the same time, do what is right for my patients and offer the most effective treatments available. For me, one of the greatest satisfactions of practicing medicine is the fact that we do things because they are the compassionate thing to do for our patients. I urge you to support this year Senate Bill number 976. This is a bill that I think will tremendously benefit our Connecticut residents.
Thank you, Darren. Any questions from the committee? Thanks for joining us today, Darren. Next up, we have Kelly Ryan, followed by Karen Healy.
Thank you. Good afternoon, everybody. My name is Kelly Ryan. I'm Deputy Vice President for State Policy with Pharma. We represent the nation's leading research-driven biopharmaceutical manufacturers. I'm here today to offer testimony in opposition to House Bill 6619, dealing with certain patent litigation settlements. I've also submitted detailed written testimony, and as I think we've already figured out today, this is an especially wonky issue. So I'm going to try to hit some highlights and zero in on some of the questions that have already come up, but certainly refer you to that much more detailed document. just to drill down on a few things that we've already discussed this afternoon. First of all, patent settlements do not and cannot extend the term of an innovator's drug. Rather, as Ashley said earlier, they generally permit generic drugs on the market earlier than patent expiration, which generates significant savings for consumers. Let me explain why. Under the federal framework within the Hatch-Waxman Act, that's the construct that helps bring generics to market. That construct leads to litigation, and patent settlements do exactly what the name implies. They settle this litigation, they save costs for both parties, and they inject certainty into this dispute. Basically, for a generic manufacturer to start the process of bringing a product to market, they need to check a box on the application to the FDA that says either the brand patent is already expired or that the patent is invalid. And this triggers litigation. That's the dance that Ashley mentioned earlier. So the brand manufacturer has to say, hey, wait a minute, no, our patent is not invalid, and the litigation starts. If they don't do that, they're ceding their IP rights. And there's a lot of incentive to be the first generic to market because you have a bit of an exclusivity period. So litigation in this space is incredibly common. In fact, in 2019, the most recent data I have, 81% of drugs that were experiencing their first generic entry faced this kind of litigation. For drugs that had sales greater than $250 million, that number is 93%. And in most cases, there are more than one challenger. So just the sheer volume of litigation in this space is pretty stunning. And if a generic company loses a patent litigation, which we've already heard happens in the overwhelming majority of the time, then it can't enter the market until the patent term for the innovator drug is expired. So by deterring the parties to reach a settlement, you're potentially delaying generic entry into the market, which then would drive up costs. It has been discussed earlier, there's substantial federal activity and oversight in this space, especially since the 2013 Supreme Court case in Actavis. And our biggest concern is this bill would inject the state into what is already an established and clear federal structure and fundamentally change some key elements of that structure, such as what the fact finder can even consider in a situation, and it upends the presumption of what is and is not anti-competitive. That's a problem because that will have a chilling effect on settlements. Competing standards at the state and federal level, confusion, the idea that a fact finder in litigation is limited into what he or she can consider is all problematic. And then the penalties are huge, frankly. They can be up to a minimum of $20 million. So that chilling effect will deter litigants from entering into settlements, which will then deter the entry of generic drugs onto the market as soon as they could be, just sort of building on some of what Ashley said earlier. I'll stop there. I can get way in the weeds on this, but I'm happy to take any questions and continue talking.
Thank you. I guess that we have heard from, the generic manufacturers and the brand manufacturers today who are both opposed to this bill, but we've had so many people in support of it. So your stance is that this is not in the best interest of the consumer, and the current system is the way to get the generics to the market faster.
Absolutely.
Okay. I will dig into your testimony and reach out with additional questions. But thank you for your time. And we have Representative Denning that has a question.
Thank you, Madam Chair. I have a question for you on, I know most patent litigation is actually at the federal level, but right now, most drug companies reach their patent level. And is it not true that they go ahead and ask for an extension?
So they may, right. So first of all, you hit on a really key point, right? The patent construct in general exists at the federal level. So there are some real questions and concerns about states injecting themselves into that construct, period. Brands may seek additional patents for different innovations. The idea that you could say, oh, I'm just going to extend an existing patent is not how patent law works. And I will caveat that with the fact that while an attorney, I am not a patent attorney, and I'm certainly happy to get you, much more detailed explanation about that, because I don't want to misspeak and delve into IP law. But extending a patent is not a thing. Frankly, you can add new patents for new innovations, but you have to go through, the process at the federal level to get that new patent on the product.
Thank you for correcting my language. However, it still delays the entry of generic drugs into the marketplace, correct? even if you decide to, for example, Ozempic is not approved for weight loss, but if when it expires as a type 2 drug for diabetes, they can again apply for an extension. We call it an extension, another reason, and Ozempic will then become not a generic drug, because you will fight and sue them to stop them from going against your patent. Am I correct?
So as a representative of a trade association, I certainly cannot speak to, what any individual member or any company that's not a member is going to do when it comes to protecting their IP. I will say, I know that Ozempic has been an issue, and there's a bill in Connecticut that we are not engaged on at all. But indications for a drug and patents are two completely separate things. So the idea of adding a new indication for weight loss, that's not the province of patent law.
If we were to work on the federal level or find a way on the state level to go ahead and approve generics after their first entry into market, that would allow generics into Connecticut faster. Am I correct?
So the first entry into market, it references generics coming onto the market, right? And so the average, let me see what I have. So there are data, and I'm certainly happy to share this study. The average of first entry into market, so the end of the market exclusivity period, right? I'm trying to not use the 50 million acronyms I have on my notes in front of me. The average market exclusivity period, which is, the time when the brand has, is the only player in the market, has remained relatively stable from 1995 through 2019. The idea that this is extended across the board dramatically is inaccurate according to the data. And right now it's about 13 years if you look across the board.
That's a pretty long time. I think one of the things that this committee is looking at, and correct me any of the members if I'm wrong, is why are our drugs so expensive when some of these drugs have been around forever? And as I mentioned earlier in the day to someone else, they make more fentanyl in Mexico that arrives in this country than arrives through people actually making fentanyl for hospital uses. And we have to figure out a way for Connecticut citizens to keep their drug costs down. And I think we should continue to meet with you and learn more about why you have a 13-year patent when most patents, as I understand it, were for 7. And I'm not a patent lawyer either. What I am is a frustrated practitioner that can't understand why these drugs are either not available, very expensive, and continuing to rise. So go ahead.
I'm absolutely happy to continue the conversation. I'm just across the border in Albany, and I come to Hartford a lot. I'm always happy to be at the table. I've been participating in some of the cost driver and solutions conversations. And I know this has been a long day, and that's a separate subject, so I'm not going to go way down the rabbit hole on all of our policy solutions, but in this setting, but 100% happy to continue having this conversation. Happy to be at the table. And I will just point out that the net price of brand drugs has been at or below the rate of inflation for well over 5 years. The piece of the healthcare dollar floats around 14%, and that has been stable for a number of years. That continues to be stable for a number of years. Folks like to cherry pick different studies and, say, oh, this number of drugs have a problem, and not look at the whole system, and then you try to apply policy solutions to a whole system. So I really would love to continue having this conversation. On
Thank you.
Thanks.
Thank you, Kelly. Any other questions?
Rep Meskers is online with a question.
Rep Meskers, welcome.
Thank you. Hold on one second. I'm just trying to get my you can hear me now.
I can hear you now.
You and hear you.
Okay. So I just want to make one comment and a response to the testimony. According to any of the studies I've seen from the OECD, in the US, we spend about 4 times what they spend for pharmaceuticals in the rest of the developed world. 4 times. Not once, not twice, not 3 times, but 4 times. So there's either something wrong with the patent law, or there's something wrong with the pricing and competitiveness of the market. The fact that we have insulin going for $440 a vial, which, you know, the delivery system has been adjusted, but I believe the essential recipe is over 100 years old. There are problems with our patent law. The attempts we're trying to make in Connecticut is to provide our consumers with an effective price. You know, this isn't within our purview, federal law, but the idea that the US should pay a premium over the rest of the world, have the best development of drugs and have the best pharmaceutical companies, I'm the first one to march up that hill and defend the right of the pharmaceutical industry to make excess profits in the United States versus the rest of the developed world. But the question is, should it be 10, 20, or 30% more than they're charging in Germany, Italy, England, Sweden, Switzerland, you name it? The fact that we're paying 4 times, you're seeing it in the cost of healthcare. You're seeing it in my tax dollars supporting the healthcare insurance policies that I personally am a beneficiary of, and all of our state workers. You're seeing it go into our Medicare, which is beginning to negotiate drug prices. I think if we fail to look that the system is broken and the pricing is getting out of control and don't address it, we're all facing a calamity. So I appreciate your testimony, but I think, you know, there is a problem here that needs to be addressed.
Yes, thank you, Representative. I know we've talked about this before, and I think we would agree the system is broken. And your example of insulin is a great example, right? The list price of insulin has gone up, but the net price has actually gone down. And so that gap, and I'm just using that as, you know, that class is sort of the poster child of an issue that we've been talking about for a long time. That gap between list and net price, more than 50% of spending on brand drugs goes to players in the system other than the manufacturers who take the risk, develop the medicines, and manufacture the medicines. Like, the system is 100% broken, and I'm happy to keep working towards a solution.
Thank you. I appreciate that.
Thank you, Kelly.
Thanks.
Next up, we have Karen Healy, followed by Gianna Dill. Okay, Gianna Dill is up, followed by Sam Hellmeyer.
Hi.
We can hear you and see you. You can go ahead.
Thank you. As a teenager, I bet for all of you, being sick was probably the least of your worries. For me, it's been the complete opposite, with my younger brother having his own medical issues. His issues have triggered mine. I've had horrifically vivid hallucinations. I've lost speech and muscle tone and the occasional ability to see. And that was all because of a cold. I was diagnosed with pediatric acute onset neuropsychiatric syndrome at 13. Shortly after that, September had rolled around, and I remember sitting in the front seat of my mom's car, having my head thrashed to the side uncontrollably and making these clicking sounds. And I was unaware that I was doing it. I was unaware that my vocal cords were producing these sounds, and I thought that it was all coming from the radio in the car, not from my own body. I was absolutely terrified. Get so angry at the smallest inconveniences. I'd scream on the top of my lungs for hours, and then just fall asleep from exhaustion. After the rage came the absence seizures that turned into drop seizures that morphed into its own weird subcategory. Although these episodes were significantly different, there was one thing that they all had in common. My pupils would dilate. to what my mother would call dish saucers. They would become twice the size they normally were. I developed unhealthy eating habits. I wouldn't eat. My depression increased. I was antisocial and not who my parents, my family, my friends, and even I knew myself to be. We began part of our treatment. That treatment took $15,000 raised in a GoFundMe, but still I was in absolute agony, sleeping 20 hours a day and being unable to control my body for over a year. It's been exhausting, degrading, horrific, and painful, and so much more. Just last week, I started my first dose of IVIG. And slowly but surely, I'm beginning to feel changes. But a year and a half ago, this could have been covered.
Gianna, thank you so much. Your 3 minutes have eclipsed. Please summarize.
If this bill is able to be passed, so many more children and kids just like me could be able to feel better and not be sick quicker.
Gianna, thank you for coming. I saw you here earlier and it was, great to hear the testimony from your mom. And it's great to see you healthy and being able to testify and sharing your story with us today. Any questions from the committee? Great. Thank you, Gianna.
Yep.
Next up, we have Sam Hallmeyer, followed by Alex Vogel.
Ooh, thank you, Chair Wood, Chair Cabrera, and members of the committee. My name is, for the record, my name is Sam Hallmeyer. I am here with the Pharmaceutical Care Management Association, otherwise known as PCMA, and we are the National Trade Association for America's Pharmacy Benefit Managers, PBMs. PBMs administer the prescription drug benefits for more than 275 million Americans through large employers, such as health insurers, labor unions, and federal and state plans. I'm here today to testify on two bills. The first one is to oppose Senate Bill 976, which deals with various coverage mandates, specifically on prescription drugs. And I'm also here to support House Bill 6619, which deals with pay for delay tactics by drug manufacturers. I did submit written testimony today, so I will keep my comments brief, but I'll go ahead and dive right in with Senate Bill 976, which will require various coverage of certain health condition drugs. PCMA doesn't oppose covering drugs for certain health conditions, but we do oppose the idea of these open formularies when it comes to prescription drugs in various sections throughout the bill. We also think that it should be up to the health plans to build these benefits as they know their membership best and what they can afford. Open formularies and copay caps take away competition and drive up the cost of prescription drugs. Next is House Bill 6619, which would ban pay for delay tactics by drug manufacturers. PCMA actually applauds the membership of this committee for recognizing that greater competition in the prescription drug market will lead to lower drug costs for patients. Drug manufacturers alone set the price of drugs, and they alone can lower or raise their costs. Instead, they block competition and then raise prices and then blame others in the supply chain for those same high prices. This was highlighted in a recent New York Times article on a manufacturer of Humira, generating over $100 billion by gaming the patent system and blocking more affordable competitors. But that's just one example. Other manufacturers have employed these same tactics and continue to do so. I appreciate the time to oppose Senate Bill 976 and support House Bill 6619, and I'm happy to answer any questions at this time.
Thank you, Sam. So you've heard the testimony from the generic drug manufacturers and pharma, who basically gave an opposite testimony, saying that this would actually cost consumers more and not be in the best interest of the consumers. We're hearing two different stories. Can you explain further?
Sure. PCMA's perspective that the more drugs that are on the market that compete against each other, lower costs are. You mentioned generics earlier. Generics typically have a much lower cost. We find the same. We find that to be the same, and that's our perspective.
I mean, makes sense, you know, and we're hearing from those two testimonies that this would cause generics not to get to market as fast as the current system, guided by federal law, is in place. What are your thoughts on that?
Thank you for the question. I don't fully understand that logic, and I'd love to hear more about it. I know I did hear the testimony, and I myself am trying to figure out the process behind why that would raise costs and cause delays, but we see the opposite, that, you know, the less delays there are, the more competition and lower costs.
Are you familiar with the California pay for delay model that passed?
I am not, and I made a note of it, and I'd love to
Okay.
take a closer look at it, but I'm not familiar at this time.
We also heard the potential for opening up, passing this bill would open up Connecticut to potential lawsuits. So I just wanted to ask if California was experiencing anything like that.
Thank you for the question. Yeah, thank you for the question. I'd take a closer look for you, but I don't
Yeah,
know right now.
We can follow up on that. Any other questions?
Uh,
Great.
Rep Meskers has a question online.
Representative Meskers, you're on.
Thank you very much, Madam Chair. In relation to pharmaceutical prices and your suggestions, last year or the year before, we were looking at a bill to import drugs from Canada. Given the price discrepancy with overseas prices versus US prices, where would you stand on something like that?
Thank you, Representative, for the question. PCMA actually doesn't take a position on importing drugs. Our only concern with drug importation is that the FDA has robust standards for what drugs in the US when they're sold, and we are unclear or unsure of what that would be like if they were imported from another country, such as Canada. So our concern is with the drug products themselves, but we are not opposed to drug importation. We don't take a position.
Thank you.
Any other questions? Great, Sam, thank you for being here today. Next up, we have Alex Vogel, followed by Jens Reuter.
You can hear me? Okay, and it's pronounced Jens, just because I've worked with him. Y'all can do that. So thanks for waiting out this afternoon with us. Good afternoon, Representative Wood, Senator Cabrera, Representative Pavelak D'Amato, Senator Wang, and distinguished members of the Insurance and Real Estate Committee. My name is Alex Vogel. I'm a certified and licensed genetic counselor here in Connecticut, as well as a clinical research project manager with my primary area of expertise in projects that concern genetics and genomics. I'm from the Jackson Laboratory that opened their genomics research center in 2014 here in Connecticut. So we like to focus a lot on the mechanisms of disease and trying to find a more personalized approach to treating disease and detecting disease. We see that that's the most effective way as well as the most innovative. So I'm here to talk about rapid whole genome sequencing. Typically, whole genome sequencing can take anywhere from 3 weeks to 12 weeks when people are coming in and trying to get answers for the cause of their disease, where rapid can come in for under 5 days. So the reason I'm bringing rapid to you today is for critically ill infants and children. So critically ill infants and children don't have that time to waste, don't have that time to wait 3 to 12 weeks because they could pass away or continue racking up medical bills while being in there. So there's numerous case studies of lives that have been saved with rapid whole genome sequencing because it has a 40% diagnostic rate. And one of these is Riley. So Riley was a part of Project Baby Bear that was led by Rady's Children's Hospital in San Diego, one of the initial hospitals that started offering this. And as part of their project, they saw that there was a 43% molecular diagnosis as well as a 31% change in management, meaning they were able to change what treatment was being done for these children. And Riley's life was one of the lives that was saved with this. So in the first few months of her life, Riley was smiling, happy, developing as expected. But then after those first few months, they noticed that she couldn't roll over, she couldn't sit up, she was losing a lot of motor function. And so then by the time she was 1, she was completely immobile. She couldn't sit up, she couldn't hold her toys. Her family was going through unimaginable pain. Riley went through multiple tests with no answers. Then when she was 4 or 5 months old, Riley received a panel of genetic testing that took 2 months to give an answer, but there was still no answer. Finally, being seen by a neurologist in California, she was able to get an answer in under 6 days.
I'm sorry, your 3 minutes is up. Please summarize.
So Riley was found to have infantile Parkinsonism and was able to get a treatment, and she's a thriving and happy young girl now. But she could have continued to have drastic issues with her motor function. This is a test that makes a really big difference in people's lives, especially infants and children and their families' lives, and stops them from having unimaginable heartbreak. Any questions?
Yeah, thank you for sharing that story. How much does this cost out of pocket?
$8,000 to $9,000.
Okay, and your experience has been that insurance is not covering it at all?
Here in this state, I have not experienced that, but I won't say that it's something that comes up a lot because this is for critically ill infants and children, but there are states that do cover this.
So, do you have a number of how many of these would be, or how many have been required over the last few years?
I do not.
So if Riley did not get this test, what would have happened to her?
So, I mean, it's not, so Riley would not have likely survived for very long, but they were able to get her a treatment, and it was actually a pretty easy treatment. And she would have likely been diagnosed when she was quite a bit older and would have had severe delays if she did survive.
Does she have these critically ill babies? Are they having symptoms even once they get the treatment following this, or are they able to have a full recovery?
So it really depends. I think obviously a full recovery is what you aim for, and you don't always find that, but sometimes you just find answers for families and they can prepare for something like a hospice or things like that. As much as we don't like to think about that, that answer is helpful for families to get off that diagnostic odyssey and try and start figuring out what's best for their family.
Okay. Thank you for sharing your testimony. Any questions? Senator Wong.
Thank you very much for your resiliency and being so late in the day. Talk to me about the test that you are talking about. Explain a little bit the rate of progression of medical innovation, of what this would have cost 5 years ago, if it was even possible. And I think that's the important part of, as we look at innovation and medical solutions and the idea of personalized genomic medicine. It goes back to the Watson helix of the discovery of the DNA. You're talking about 2 to 3 days of being able to get genomic sequencing to use to identify illnesses and to be able to understand some of the possible solutions. So take us through in regards to fully understand in the legislative body what Jackson Lab and its corresponding last 10 years almost in the state of would this technology and innovation you're talking about that cost 7-10,000 would have been even possible 5 years ago?
This rapid of testing would not have been possible because a large reason that they have been able to make it more rapid is the technology itself is getting shorter and shorter times to run the whole genome, because your whole genome is all the DNA in your body. It's what makes you you. And in this rapid timeline, the analysis power that goes behind that. So it's not only the running of this to get this data, it's the analysis power to really find out what's going on. So 5 years ago, no, and it would have been, even if you were ordering a normal whole genome, so that up to 3-month timeline, it would have taken an absurd amount of money. Like it wasn't even something that was on the table in the clinic at that time, because it was for people who were only of very specific means, with an exemplary amount of money.
Do you see with increased utilization and greater economy of scale, do you see with technology innovation and greater economy of scale, do you see that cost greatly reduced?
Yeah, the cost has already greatly reduced, and I see this greatly reducing, I would say, in hopefully the next couple years as we continue. More and more companies are coming out with a cheaper way to run these very advanced tests, and then we've only gotten better at being able to analyze, which would shorten our time and shorten our cost.
Thank you. Did you submit testimony today?
Yes, under Bill 976.
Okay, all right. I will look for it, but thank you very much for your time.
Yeah.
Thank you, Madam Chair.
Thank you. Representative Denning has a question.
Thank you, Madam Chair. Very quickly, where do you want to, you're a researcher. Where do you want to be in 5 years and 10 years?
That's so broad. Do you have anything specific?
The technology that you're using.
Okay.
Where will this take us? I mean, give me a vision that says moving this up to scale will benefit us in 5 years because we'll be able to do this.
Yeah, so I would say in 5 to 10 years, it's a hope that genomic medicine is more accessible to all. So this rapid whole genome sequencing that we're discussing now is for very critically ill infants, but it's the hope that in the future that everyone can have this, because there are certain public health implications for being able to screen people ahead of time for hereditary cancers, things like that, these like tier 1 conditions that we talk about, BRCA1 and 2, Lynch syndrome, familial hypercholesterolemia. My hope is that it just becomes more accessible to people, and people can determine what they want to do with that information if they decide to pursue it. And I think I believe that's accessible within the next 5 to 10 years.
Thank you very much.
Thank you. Senator Wong.
Thank you, Madam Chair. Just for a point of clarification, I was reading through. Your testimony is filed, but it's filed under Lisa Roy.
Yes.
So if we can make that correction on there for the scientists to be recognized for their testimony and their value and their contributions. Thank you.
Thank you so much.
Thank you for coming here today. Okay, we are in the final 3. We have Bright Johnson, followed by Ruth Canavi, and then Jason Lind is last.
Good afternoon. I'm Bright Johnson, Connecticut Government Relations Director for the American.
Right. I'm sorry. We actually forgot one person.
Oh, great.
We'll be going to it. Right.
Who did we forget?
No, number 31, Madam Chairwoman.
I thought that was Jens. Oh, that's Alex. Okay, Jens. I apologize for that. I thought you said your name was Jens, and sorry for messing everyone up. Can you just press the button on your microphone?
There we go.
There you
All
go.
right, let's start over again. Good afternoon, Representative Wood, Senator Cabrera, Representative Pavlak D'Amato, Senator Wong, and all the other distinguished members of the Insurance and Real Estate Committee. My name is Jens Reuter. I am a practicing oncologist and the Chief Medical Officer at the Jackson Laboratory, which you heard about from my colleague, Alex Vogel, just a minute ago. I'm here on behalf of Senate Bill 976, and specifically sections 45 and 46. And I would like to focus this testimony on biomarker testing in cancer, specifically actually broad panel genomic profiling, which we heard a little bit about earlier today already. So when we talk about broad genomic profiling for tumors, we think about larger panels that have been designed, have been clinically validated, and that can be used to identify and diagnose cancers, to identify treatment options, and then later on through various processes to diagnose a relapse or recurrence or monitor response to treatment. So this is a technology that has already made its way from the discovery phase into the clinic. It's available in a number of different assays that are clinically validated under CLIA and CAP. And up to now, they're still not reimbursed by many insurers or by Medicare unless specific conditions are met. So these tests are now critically important in the care of cancer patients. I can speak to that from my own practice. And they should really be considered standard of care, as many biomarkers actually identify FDA-approved therapies for many cancer patients. And the most relevant national guidelines, the NCCN guidelines, now recognize this in essentially all cancers, that patients, especially with refractory and metastatic cancer, should have this testing done. Just in the last 45 seconds or so, just two very quick examples. So, for example, a patient with a sarcoma that is difficult to treat, if they undergo genomic profiling, we might be able to identify, and I've seen this happen in practice, high so-called tumor mutational burden, which makes the patient a candidate for immunotherapy, which he or she would otherwise not be a candidate for. Another example is of a patient that we know about directly, who had two specific genomic variants identified through genomic profiling, for which he was able to go on two specific drugs, initially sequentially and later on in combination, and achieved a long remission because of this treatment. So I think I'm at the end of my testimony. I'm happy to answer any other questions.
Thank you. Any questions? Representative Denning.
Thank you, Madam Chair. Thank you for coming. I toured the Jackson Laboratory a week ago, and I know your major income is selling mice that all have their own little name. And I never imagined that in my life. And when I got there, there's not even one rodent in the building. Right. They keep them all over in the parking garage. And so I was disappointed. This is the future of medicine in my practice, as well as other people's practice. And I can't wait for you to continue to grow this and make these biomarkers more available so that we can understand these diseases on the micro level and even on the genomic level, so that we can, I hear you have a CRISPR device over at the Jackson Lab. And this is the kind of technology where we can insert and remove particular genomes that may make our lives better. So I applaud the work you do. I think that in 10 years, this is going to be the future of medicine. Thank you.
Thank you.
Senator Wong.
Thank you, Dr. Reuter. Thank you for being here, and thank you for your leadership and innovation at Jackson Labs. Big fan of the organization and your genomics section, which is different from your mice, Representative. You just have to go visit Bar Harbor for the mice. Right. But that being said, I think you did a very good job in your testimony explaining out what biomarkers mean. So if you could, for the sake of the broader audience that may be watching, through your genomic and personalized medicine and the expertise you bring, what are biomarkers to help identify unique set of characteristics of disease diagnostics before they occur?
Right. So that is actually a great question. So biomarkers actually include, it's a really long list of different tests that can either be done on the DNA level, which is what JAX focuses on, or on the RNA level, which is sort of the next step in the transcription process. You know, we go from DNA to RNA to protein. And then lastly, we have proteins that we can measure on tumors, or in fact, outside of cancer, it is also being increasingly done. So the concept of biomarker is very broad, and it really just means that you can identify a unique characteristic that you can then utilize in therapeutic decision-making, i.e. you can choose a drug that's specific to the biomarker that you have identified, or you may identify, as you mentioned, a risk factor, and that's often done on the genetic level. You may identify a risk marker, a genomic marker that identifies a risk for disease, cancer, or others. So those are kind of the two most common scenarios at this point. It's a very broad term.
It is, but let me narrow down to something that is relatable. One of the biomarkers you cited is the PSA tests.
Correct.
That we all know.
Yes.
For men and their prostate diagnostics, but also what we've seen in the last 10, 15 years, the BRCA tests, BRCA 1 and 2 in regards to early breast cancer diagnosis for a carrier of specific genes. That has been an incredible awareness for many, many women. But I raised that from a BRCA test is you also point out in your testimony, there's great equity issues in relation to that. Because most cases, if you have the means, it's not covered,
right?
And it's not covered under Medicaid, and as a result, an equity issue is raised for women to be able to make an advanced diagnostic of breast cancer awareness versus those that can afford paying out of pocket. So, can you explain a little bit the BRCA for those that may not be aware? But secondly, be able to give me an analysis in regards, I go back in history and maybe even 30 years ago, we talk about pap smears and being able to do diagnostics, right? And that's a biomarker as well, that we used to think it was a cost prohibitive, but it was an important factor to be able to give pre-indicators. Now, with the economy of scale that I'm always talking about, that it almost becomes de rigueur in a regular diagnostic test, and the cost is significantly bottom. As I asked Ms. Vogel, is the fact that the more testing, the more diagnostics, the greater economy of scale, the lower the eventual cost, and obviously the diagnostics. So it's a two-part question, and thank you, Madam Chair, for the indulgence of the long question, but we have medical expertise here that is greatly valued in the state of Connecticut.
Well, sure. Thank you. So I'll try to answer this, and I'll start with the BRCA example, and then I'll sort of branch out a little bit further. So, BRCA 1 and 2 testing can identify a clear risk for breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. And there are a number of scenarios where that type of testing would be perfectly appropriate and actually quite straightforward to do. So technology is no longer an issue on that level. What you can then do once you know that someone has a risk, you can put them on ideally on a surveillance program because they don't have cancer yet and can sort of either intervene early when you discover the cancer or even prevent the cancer from developing completely, which is the ideal outcome. So I think by doing that, you can both decrease morbidity, you can increase health span, and you may be able to increase lifespan. So I think, and you can avoid unnecessary treatments, or can avoid treatments that are both toxic and potentially unnecessary. So those are kind of the direct implications of the BRCA 1 and 2 testing. It is true that there are issues already with disparities. I am, at JAX, as you mentioned, Bar Harbor, we have we also are very active in the state of Maine, which is very rural, and the same is true for parts of Connecticut. Rural disparities are one issue where you simply don't have the understanding, the knowledge by practitioners, for example, even to order the appropriate testing at the right time. And you have the insurance barriers there as well. And because there's a lot of, there's a lot more underserved populations there as there are in inner cities, et cetera. So there's absolutely a correlation with the disparities issue. The other part, though, just moving away from the BRCA 1 and 2 testing, is that we've also known now that there are many other potential risk factors that we learn about over time through scientific discovery, and that we can then turn into a diagnostic test and assay that is validated, meaning that it can actually show what we think it shows, right? It's done under very strict guidelines, and we can do similar things there as well. So the broader, what we call the broad genomic profiling, where you look at, 500 genes or more, or you look even at the entire genome, like what we just heard about the sick baby scenario, you can do that in cancers as well, and you can discover other potential targets that might be targetable on a clinical trial. You can identify other predispositions that we will learn about over time But unless the testing is always the first critical step. You will not know about a patient's risk for developing a disease. You will not be able to tailor treatment to the disease once it has developed if you don't do the testing up front. So that's really the critical piece. And I think it's nicely addressed in the current version of the bill, where basically the idea is that you have to meet certain diagnostic criteria. You can't just, in your back garage, develop your own test and say that this should be covered by insurance. You have to go through a validation process. But once you've gotten there, it should really be covered by insurance because it's so critical in the treatment of patients. So I hope that answered the question.
Thank you very much. Thank you, Madam Chair.
Thank you for your testimony and joining us today. If you need any guinea pigs, we're at your service.
Thank you.
All right, so now we're back to our final three, which I apologize for. Bright Johnson is up, followed by Ruth Kanavi. Is Bright on remote? Great.
There we go. Good afternoon. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network and a resident of West Hartford. Regarding SB 976, ACS CAN is in strong support of sections 45 and 46 pertaining to biomarker testing. Timely access to guideline-indicated comprehensive biomarker testing will enable more patients to access the most effective treatments for their disease and can potentially help achieve the triple aim of healthcare: better health outcomes, improved quality of life, and reduced costs. This legislation will ensure Connecticut residents covered by state-regulated insurance plans have coverage for biomarker testing when medically appropriate. Progress in improving cancer outcomes increasingly involves the use of precision medicine, which uses information about a person's own genes or proteins to prevent, diagnose, or treat diseases like cancer. Biomarker testing analyzes tumor samples to identify mutations that may impact treatment decisions. This testing is an important step to accessing precision medicine, which includes targeted therapies that can lead to improved survivorship and better quality of life for cancer patients. The number of targeted therapies that require biomarker testing is increasing rapidly, and cancer clinical trials are increasingly driven by biomarkers and the development of targeted therapies. For example, nearly 60% of all cancer drugs approved by the FDA in the last 5 years require or recommend biomarker testing before use. 55% of all oncology clinical trials in 2018 involved the use of biomarkers, as compared with 15% in 2000, and that number is only increasing. Not all communities are benefiting from the latest advancements in biomarker testing and precision medicine. In Connecticut, 60% of policies reviewed were quote unquote more restrictive than NCCN guidelines for biomarker testing for breast, non-small cell lung cancer, melanoma, and or prostate cancer. Communities that have been marginalized, including communities of color and individuals with lower socioeconomic status, are less likely to receive biomarker testing. People in rural communities and those receiving care in non-academic medical centers are also less likely to benefit from such testing. Ensuring equitable access to biomarker testing by improving coverage for and access to testing across insurance types is key to reducing health disparities. Indeed, without action like this to expand coverage for biomarker testing, advances in precision oncology could increase existing health disparities. Both the National Black Caucus of State Legislators and National Hispanic Caucus of State Legislators adopted resolutions recognizing the importance of biomarker testing in advancing health equity and reducing disparities. Currently, 18 states across the country are working on biomarker testing legislation, while 4 states, Illinois, Louisiana, Arizona, and Rhode Island, passed this legislation in 2022. Thank you.
Thank you, Bright. Any questions from the committee? Thank you for being here today. Next up is Ruth Kanavi, followed by Jason Lind.
Hi, good afternoon, distinguished chairpersons and members of the Insurance and Real Estate Committee. My name is Ruth Kanavi, and I'm the Director of Advocacy for the American Lung Association in Connecticut. The Lung Association is the oldest voluntary public health association in the United States, currently representing more than 36 million Americans living with lung diseases, including more than 1,800 individuals who will be diagnosed with lung cancer in Connecticut this year. The Lung Association urges you to support Senate Bill 976, specifically sections 45 and 46, to increase coverage of biomarker testing, as this legislation will improve access to critical cancer care for patients in Connecticut, including those with lung cancer. Comprehensive biomarker testing allows doctors and healthcare providers to identify abnormalities in a tumor's DNA, which in turn helps healthcare providers determine the best course of treatment for cancer patients. This is particularly important when treating lung cancer, as there are currently FDA-approved lung cancer treatments for tumor abnormalities in 7 distinct genes. Studies show that lung cancer patients that have access to biomarker testing and are thus able to receive targeted therapy treatments have better overall chances of survival. Biomarker testing is a crucial part of cancer care and has been incorporated into many clinical guidelines so that healthcare providers may make the best decisions for their patients' health. Despite the evidence for the value of biomarker testing, most healthcare coverage plans have been found to be more restrictive than the National Comprehensive Cancer Network's guidelines for biomarker testing. And many patients who should receive biomarker testing may be unable to do so because of insurance coverage restrictions and high out-of-pocket costs. Therefore, it's important this legislation or any policies that pass increase coverage of this testing and remove some of the barriers to care. We're also offering testimony today in the Human Services Committee to ensure coverage of biomarker testing through Medicaid program in Connecticut as well. So thank you for your time. Increasing coverage of biomarker testing will improve health equity, as you've heard today in Connecticut, and make cancer care more affordable and accessible for patients. So thank you so much for your time. Really appreciate it, and we're happy to answer any questions if you have any.
Thank you, Ruth. Any questions from the committee? Senator Wong.
Thank you, Madam Chair. I just wanted to extend my appreciation for the great work of the American Cancer Society for your awareness program. And I didn't get to say that with Bright, and thank you for your work as well, Bright. Thank you, Madam Chair.
Thank you, Senator.
Thanks for joining us today.
Thank you. Take care.
And last, we have Jason Lind.
Yes, co-chair Sarah Cabrera, Representative Wood, ranking members Sarah Wong, and Representative Pavlak D'Amato, and members of the Insurance and Real Estate Committee. Thank you for your patience in this hearing. My name is Jason Lindy, and I'm the Senior Vice President of Government and Community Relations at FAIR, Food Allergy Research and Education, the nation's largest nonprofit engaged in food allergy advocacy, speaking on behalf of the more than 350,000 Connecticut residents with life-threatening food allergies. Connecticut's food allergy population is larger than the combined cities of Bridgeport, Danbury, and New Britain, and many years ago included my son, who was born at the wonderful Grisman Hospital in Derby and has a finfish and shellfish allergy. FAIR proudly supports SB 976, especially sections 35 to 38, which makes epinephrine auto-injectors affordable for all Connecticut residents, especially those hardworking families and individuals who have high deductible health insurance plans. A recent NBC News story captured the problem this bill solves when it reported that even as the cost of EpiPens and other epinephrine auto-injectors have stabilized, many are paying thousands of dollars out of pocket each year due to high deductible insurance. And for Connecticut residents, that's the majority of the state's private sector employees. In 2021, 54.4% of the state's private sector employees were enrolled in high deductible health plans. For a family in this plan with a 14-year-old with life-threatening food allergies, who will require a pack of epinephrine auto-injectors both at home and at school, that means the annual trip to the drugstore to pick up 2 sets of EpiPens could cost up to $1,400 in out-of-pocket costs, which is more than the average monthly mortgage payment in Waterbury. Let me repeat that. 2 packs of life-saving medicine cost more than a mortgage payment. This is the reality for thousands of Connecticut residents through no fault of their own. And the alternative is to go without, and that has deadly consequences. In the past month, 3 children have died due to anaphylactic attacks. One of them, a 10-year-old girl named Emerson Kate Cole, passed away in Amarillo, Texas, because her epinephrine auto-injector was locked up at school and could not be accessed. We need your help to unlock financial barriers our families face, especially when epinephrine shouldn't be so expensive. CNBC estimates that the medicine in EpiPens costs $1. And the San Jose Mercury News found that it costs $8 to manufacture a 2-pack epinephrine auto-injector, while your bill would set the price at $25. Well, SB 976 offers a win-win solution for food allergy families and manufacturers. Families won't have to worry about paying for life-saving medicine, while manufacturers would reap a 212.5% profit on a product with ever-increasing demand. We strongly encourage the committee to pass SB 976, and I'll be happy to answer any questions you may have. Thank you, and I hope you have a wonderful Valentine's Day.
Thank you, Jason. Any questions from the committee? Thank you for sharing those statistics with us. It's always shocking every time we hear them, and I think it really hits the point home.
Well, thank you, Chair. It's also in my written testimony.
Yeah, perfect. We
Okay.
saw it. It's very
All right,
helpful.
great. Thank you so much.
Thank you. That is the end of our hearing today. Do we have a motion to adjourn? All those in favor? And we're adjourned. Have a wonderful Valentine's